session, I would like to invite first chairperson, Dr. Sangeeta Srivastava, general practitioner with 32 years of experience and ex-president of IMA Navi Mumbai. Second chairperson, Dr. Yogesh Dudi, intensivist at Terna Speciality Hospital. So would like to invite our first speaker of the day, Dr. Nikhil Varghese sir, who will be leading today's session. Will discuss about essential step in initiating mechanical ventilation. Dr. Nikhil Varghese sir is an associate professor of medicine and consultant in internal medicine and critical care at Terna Medical College and Hospital. He is a medical director of Acharya Shri Gnanesh Hospital in CBD Belapur and executive committee member of ISCCM Mumbai City branch. Welcome, Dr. Nikhil Varghese sir.
Good morning all. I welcome you again today for the second day of Airway and Mechanical Ventilation Workshop, which is being jointly organized by ISCCM Mumbai City Branch and Department of Critical Care at Terna Speciality Hospital and Medical College Institute. I know I had to start the opening batting, and it's difficult to pay attention to. I can see the dwindling crowd numbers. The reason is simple, because the topic is complex, but our attention is at somewhere else. We know the initiation of mechanical ventilation is an important strategy, and all of us should definitely understand what it means, because it is a situation when the breath needs a breach. So, of course, most of us have this in mind today. Yeah, there's a Asia Cup final that is going to happen today evening. And with the high-stake rivalry, we have already won 2 games. This is the 3rd game in the same series where we will be facing our arch rivals Pakistan again. And as the stakes are high, our all attention is there. But I want you to pay attention to this session also, because yes, there will be quiz and there will be prizes to win. So when we talk about ventilator, we all understand that ventilator is a very important piece of machinery that makes a difference in an ICU. We all know that ICU probably is now synonymous with ventilator, and ventilator is synonymous with ICU. The awareness of ventilator has reached to populations. We have seen movies being made about ventilator, and people's perception about ventilator is changing. Because at one point of time, people used to think ventilator means a dead end. There is no coming back. But situations are changing, and we expect. As Amala madam told you yesterday, that when dealing with airways, similar situation is with ventilator. Many of us deal with ventilators in emergency rooms, which are full of chaos. Lot of patients coming around. We have to make decisions. We have to make a fast assessment of patients and decide which patients are going to get benefited. Some of us deal with ventilators in operating rooms, where the environment is slightly calm, composed, where we have a stable patient. The details of already are known to. We know what medications this patient is taking, and the situation is managed by a team of experts, supervised. But most of us deal with ventilators in ICU. And as yesterday Gunjan madam has specifically pointed out, this is that 4 a.m. scene. Something goes wrong with the ventilator and patient, and then we are struggling what to do, what to look at, what parameters to observe. And as happens in most of the hospitals, night 10 p.m. to morning 8 a.m. is a time for experiments. Many times new admissions happen during these hours, and the emergency doctors and the ICU doctors are struggling with the patient. Yes, at times we end up losing, like the Bangladesh team lost few days back. Nobody thought that Bangladesh would lose to Pakistan that day, right? But as Sandeep sir was also pointing out, sometimes when we intubate a patient and put him on the mechanical ventilation, we feel, yes, we have achieved something of a feat. And we feel that the life is saved. But all of us, including most of us who have years of experience, have lost patient within 24 hours of putting on ventilator. The situations are different. At some times, we have some expert who comes to our help, clicks few knobs, touches few buttons, and our distressed patient seems to breathe comfortably. And I would want all of you to become that kind of experts after a couple of days of intensive learning on this topic. Because the challenge is different. We have been seeing ventilators for years. Almost for 90, 100 years, the ventilators have evolved over a period of time from this negative pressure ventilations, which were outside the body and were used for patients with poliomyelitis. And remember that many patients have survived on these machines also for years. To new age ventilators, which have modes called as IntelliVent, where you just have to connect the patient to a ventilator and the ventilator will derive all its necessary information. You have to just put height of the patient. It will calculate ideal body weight. It will look at the lung dynamics, what the resistance is, compliance is, and it will adjust the settings in such a way that patient should have minimum work of breathing. This can be applied to any condition, any patient, and it itself will decide when the patient is improving to good enough level where patient can be given a weaning trial. Now having such ventilator is going to be fun and help. But then I remember this legend. Most of the millennials and some of the Gen Zs might know this face. This guy is Michael Schumacher, who made Ferrari what Ferrari is today. And the guy used to say, a machine is as good as the operator is. So even if we might get new age ventilators in time, you ought to know how to manage your ventilators, what understanding from the ventilator will come, what troubleshooting you will have to do. And the most important task is when to initiate the ventilator. Because in the silence between the gasps, we become the architects of breath. Now, as we discussed yesterday in Amala ma'am's lecture, that when to intubate is a decision. Similarly, when to intubate is in kind of crossroads that we always come across. We have to know when we have to intervene. What is the right moment that we have to intervene? What are the right tools to go? We all know that respiratory failure becomes the prime most indication for putting the patient on mechanical ventilation, or impending fatigue because of certain other conditions, like in a patient who is having some kind of acidosis because of multiple reasons, a patient who has heart failure where the breathing efforts are too much. Patient might not have immediately visible signs of respiratory failure, but the patient might have altered sensorium. That can be because of poisoning, that can be because of metabolic encaves that leads to CO2 retention with a declining GCS. We might face a patient who has just come out of a cardiac arrest and which needs a breathing support as a part of resuscitation. We all have to understand that ventilation is just not a reflex action, it's a calculated rescue intervention. So your intervention has to be tailor-made. As we used to do in ICUs, that whenever a patient comes to ICU, we used to look at what is the indication of bringing this patient to ICU, so that you understand your approach and you understand when this patient's need for ICU is over. So if the patient is coming for shock, you treat shock. If the patient is coming for respiratory failure, you treat respiratory failure. Similarly, whenever you are putting a patient on a ventilator, you also have to look at what indications we initiated the intervention in the first place. We know hypoxemic respiratory failure still remains the most common indication of putting the patient on mechanical ventilation. Hypercapnia, that can be of multiple etiologies, but most common being COPD exacerbations. Increased work of breathing in certain situations where the patient is already in shock and acidosis. And respiratory risk because of certain causes like poisonings or intoxications. All we have to understand that what is the tipping point, because too late intervention might not help. So you have to understand that tipping point. Understanding that tipping point is an art that you will develop over a period of time, observing patients. What your seniors expect us you to understand is you should be able to recognize when the patient is going bad. Probably that is the moment where the science will come, because when you initiate a support, you have to be backed with the science. Again, this slide is same as what madam had. Your patient will have a diverse presentations. Your patients will not be homogeneous. Some patients will have pulmonary edemas, some patients will have ARDS, some patients will have consolidations, and so on. Some patients will have pneumothorax, some patients will be post-op. So your ventilation needs will change as per your requirement of patient, and that thing again has to be kept in mind. And then comes the art of assessment. We can remember that before using the tube, we should use our brains. again to assess the situations properly. That we get a variety of tools. Maybe it will take 3 to 5 minutes to run some point of care investigations. You should look at the ABGs, what abnormalities are predominantly present in your patients. Looking at the lactate levels, that will also indicate the severity of your respiratory failure and tissue hypoperfusion, for how long that has been. You can do some physical examinations where you can look at the patient characteristic, whether the patient is tachypneic or patient is bradypneic, whether the patient is having neurological obturations. We do in ICU, our staff nurses do commonly in patients with neurological disorders, the GCS assessment. And you also have to understand what is the hemodynamic status of the patient, because once you put the patient on positive pressure ventilation, the hemodynamics are going to go for a toss. You all have seen ventilators. You understand what the common things in ventilator are. You understand the main machine. So there are certain ventilators with compressors, with some with turbines. So breathing circuits, humidifiers, patient connections, and the most importantly, when you monitor, you have to understand what there is on the screen. So there are different types of ventilators. Some of us have worked with T-bird ventilators, which used to give just some numbers. There were no loops or graphs then. Now, fortunately, there are loops and graphs, and also there are automated value derivation from those ventilatory parameters. We know that we already have yesterday dealt with this. In Gunjan ma'am's talk, you heard about what the modes are and what would be a preferred mode to choose for. So we commonly use modes of volume control and pressure control. You already know the pros and cons of both. You already understand, because I'm expecting that there will be questions coming about that. What are the timing, cycling, and controls that we put in the ventilators? So these are the commonly used modes. So you can understand that you have to deliver a volume, the breath should be assisted, you have to use a pressure control so that the ventilator associated injuries are not there, and patient synchrony is something that you have to constantly look at. So now the question to you guys: when you have a patient, as madam has said, Amala madam had given you an example that a patient without a known history, without a file, was rushed to the ICU. Can someone of you tell me what initial settings you would like to start this patient on? Mic do na Manju. Anyone? What volumes you would like to set? I hope everyone had a coffee and tea. Yeah, 6 to 8 ml. But that's a common thing that we go. 6 to ml of what? 6 to ml per kg of what?
Predicted body weight.
Ideal body weight. And how do you calculate that?
So for men it is 50 plus 2.3 height minus inches, or
So we are not going to take into account body morphology of a patient. We are going to calculate the ideal body weight depending on the height of the patient. So why 6 to 8 ml and why not more?
so now we are doing low tidal volume ventilation.
So we want to be safe. So I think we not only have to be safe, but we also have to act smart. 6 to 8 ml, it's a correct answer that we would want to start the patient ventilating at 6 to ml per kg. And what respiratory rate? Generally 12 to 16. Is this a good setting? FiO2 of 100%? Because we are expecting that during intubation some hypoxia has happened, and PEEP of 5. This is what we discussed yesterday. Will this setting suit all? No. Why? Because the patient characteristics might be different. So if, for example, you have a patient who is severely acidotic and is trying to hyperventilate, and if you put him on a control mode and you sedate paralyze this patient, and then what is going to happen? Probably the compensation is gone, the acidosis will worsen, and the patient can collapse. So yeah, this could be an initial strategy for most of the patient, but you will have to individualize. So don't chase the numbers, we have to chase the physiological endpoints and patient comfort here. So next point, once you initiate the patient on ventilation, is an important strategy where you will set alarms. What alarms you set on a ventilator? Achha. बोलो बोलो जो भी है. What alarms you set on a ventilator?
Pressure alarm.
Okay. What pressures you set? What is the maximum pressure you allow to your patient to go to?
35 to 40. 35 to 40 of peak
35 to
length.
40. So in a ARDS patient, slightly higher, and a otherwise patient up to 30 is probably good enough. So we have to set the alarm. That is for patient safety. And ventilator alarms, once you always remember that when you initiate a ventilator, you must set the alarm in a proper way. What kind of volume you want, what is the maximum volume, what is the minimum volume, what is the maximum pressure, what is the minimum pressure, what is the apnea time, what is the FI2. Because there have to be considered that if the patient is not doing good, there can be factors which are related to your patient, and there can be also factors which are related to your machines. So setting alarms is a very important strategy. We have to set the pressure alarms, we have to also set the volume alarms, we also set the respiratory rate alarms and apnea times. Okay, after say if the patient is not breathing for 10 seconds, setting the apnea will not be useful, but at 15-20 seconds, if the patient is not breathing, should be having a backup mode going to. So the next important part, once you initiate the ventilation, which will happen in next couple of hours, is monitoring the machine. See, the ventilator is your partner and not your boss. You will have to give the instructions. If you give your instructions properly, then only the ventilator will do its job properly. So you have to look at the oxygenation. As madam has again told you yesterday, that capnography is also important when it is available. So we have to look at patient synchrony and lung mechanics. Lung mechanics is all of other things generally you do. You look at oxygen levels, you look at EtCO2s. Patient synchrony and lung mechanics is something that the commonly that doesn't come to our mind that commonly. We are used to look at the monitors. Now we'll have to be used to getting associated with the ventilator screen. So I'm just giving you a demo of a ventilator screen. Can you see this? Neglect that alarm of low SpO2 in a demo mode, that will not be there. So this patient, again, similar situation. No patient record, patient was brought to emergency, first time hospitalization, admitted, ventilated. If you look at the ventilator, what do you think are the abnormal parameters here? Can someone guess? Fortunately, newer ventilators will have this function of monitoring, where you can get values actually. But what is the use of these values if you cannot make an interpretation out of it? So many values. What do you think are important values here? Yeah, so this is a advanced ventilator which has a EtCO2 function. But otherwise, do you think that yesterday, that's why I'm going to tell you that you have to go back and visit yesterday's talks. Can you see this value 1.69 here? What is that? Madam has specifically told you in that loop and loop section. What is this? This is the expiratory time constant, where madam has explained to you how much breath is going to go out in first, second and all, and what is the normal value. So what does respiratory time constant indicate? Even if you don't know the history of patient, you can calculate that this patient is in case of obstructive airway disease with prolonged expiration. So if your ventilator doesn't have that kind of ventilatory function, can you calculate the resistance by yourself? We have seen the manuals calculating P plat, P peak, P plat, you know. Okay, so what is resistance? So we have to understand that the resistance is going to be an obstruction from the patient side to the ventilator effort. So there can be multiple issues. One can be the tube itself being small, or tube positioning, tube kinking, other ways. But if you look at the lung parameters, the airway is the main reason the lung there will be resistance for. And what is the clinical significance? Yes, it is increased in patients who are having obstructive airway disease or having bronchospasm, or if there are secretions present. And how do you calculate? You should be able to do that, even if your patient, even if your ventilator is not giving you values. So the formula we all know. Resistance is calculated by PIP minus P plat on the flow. And how to calculate flow? Because this is supposed to be workshop, so I am trying to give you this. So in this, where you will calculate the flow? So we can have a hold and we can have a freeze on this. So you have to freeze the screen, and this center loop of flow, you'll have to calculate the flow at the start of expiration. Can you see the inspiration and expiration on the pink line? When the expiration starts, you have to freeze it and bring the cursor there, and it will give you flow per second, liters per second. So you can use that values and put it in this calculation, and you can get the value of a resistance. So if you have a respiratory expiratory time constant, well and good. Otherwise, you can calculate the resistance even if you don't know the patient dynamics and patient history. See, this is kind of a bedside assessment. Even if before the patient X-ray comes, echo comes, and like you do a ABG, you can get a value about it. We are traditionally being taught that already that if both are increasing, peak pressure is for air resistance, plateau is for compliance, right? So if both are increasing, then you will think of what condition? Peak and plateau, both pressures are increased. What condition? Only peak increasing, plateau not increasing. Which condition? Yeah, so these are the things that you have been taught. You have to keep remembering that. Do it on a daily basis. Calculate resistance in your ventilators whenever you see a patient. Same thing I'll talk about the compliance. What is compliance? Compliance is basically elasticity of the lung. So madam has told you to look at the loops. That is easy way of doing it. That you had a loop. You remember yellow, green, red? When the loop was moving on the right side, so more pressure was required for the same amount of volume. So that means the compliance of the lung was decreasing. Can you do it in a theoretical way? So you can do it in theoretical way. Okay, you can do it in theoretical way. We'll again go to the same ventilator screen. Here there are already certain values. Okay, here the peak pressure is 21, plateau pressure is 15, and the PEEP is 5, and the volume is almost 600 or 650. So if you put these values in the same formula, so volume is 600 and P plat minus PEEP, so the value is 10, 15 minus 5. So the compliance is coming to 68 approximately, or 65, which is a good compliance. So now in a patient where you don't know anything about the patient, looking at the ventilator, you calculate that this patient had more resistance and good compliance. So likely condition is emphysema or COPD. So that is what probably is the next level of monitoring should happen after initiating the mechanical ventilation. Of course, you are going to look at what tidal volumes are delivered, what is the pressures are going at, and you know the holds and inspiratory holds and expiratory holds to understand the use of it. Now as far as the compliance is concerned, there are slightly different values of two, which is a dynamic compliance and static compliance. Okay, we just calculated the dynamic compliance, and there is a static compliance calculation too. You should remember these. Now already you have learned yesterday, I am not going to detail of ventilator waveform analysis. We understand what pressure time waveforms are, what flow time waveforms are, what is volume time thing, and what are our loops. So now we'll go to the next section, what you will do while troubleshooting the alarms. What are you going to look at if the high pressure alarm is looking at? You intubated a patient, you put the patient on mechanical ventilation, and you move to the next patient after spending half an hour with one. And after half an hour, the sister comes and she says, "Sir, there is a high pressure alarm coming on the alarm." So what will you tell the sister who is coming to you? Sister, silence the alarm, right? Nobody wants a noisy environment in the ICU, particularly at 4 a.m. in the night, right? So when there are high pressure alarms, you have to think that there can be factors associated with machine, circuit, as well as the patient. And patient factors are the most important. Yes, the patient might be coughing. There could be presence of secretions. The tube might have kinked. There might be a bronchospasm. And then, yes, immediate some sort of action is required. But unless and until you do an assessment of it, is it possible? You cannot just, paralyze the patient. No. The alarms are there for some reason, and you are supposed to interpret them and act on them. Then there can be alarm of high respiratory rate, which means the patient could be in distress, pain, the acidosis might have worsened, hypoxia might have worsened, then you need to look at there. If there is a alarm of low pressure or volume related alarm, there can be reason which is like leak, disconnections. Somebody does a suction and sister fails to turn off the knob. Then there is a leak. And apnea alarms. These are particularly important if your patient is on assisted modes or on a weaning trials. So when the alarm sounds, always look at the patient first and then look at your ventilator. Ventilator is not giving alarm just for the sake of it. Patient synchrony is an important part. We have to understand that the patient should be able to breathe in harmony. So if you see a patient who's in desynchrony, what do? Sedate and paralyze. Is it so? Is this the reflex action that you all take? No, we have to understand, okay, if the patient is not breathing in synchronous, what is the problem? Is there a trigger asynchrony? That is patient trying to, have we not set the trigger right? Patient is trying to breathe but the trigger is not getting appreciated. Is there a flow asynchrony? That patient is actually trying to breathe more over top of your ventilator. So that is had to be looked at. Are we over delivering the breath? Cycle asynchrony. So patient is trying to generate its own breath. At the time the ventilator wants to push the air in, the patient is trying to expire. So that is a cycle asynchrony. And mode is synchrony. Probably we are choosing a wrong mode. Maybe your patient is now on a recovery phase. Patient is trying to breathe. He is comfortable. He is not on sedation. So probably you should be able to look at if the modes have to be changed. Achieving synchrony minimizes patient's work of breathing, improves gas exchange and enhances comfort, leading to better outcomes and shorter ventilation durations. And then comes the next investigation, which is bedside X-rays. Most of the ICUs do have a protocol of doing X-rays daily. You have to look at what are the ventilator associated problems. Yes, one thing that we are all concerned about is ventilator associated pneumonias, and they are very common. In our ICUs where the standard protocols are being followed, still we get a good amount of patients who are having VAF. Barotrauma, yes, because of our safe ventilation, generally the barotrauma is less, but still you have to look at if there is sudden hemodynamic instability. Again, look at whether your required volume can be lowered, whether the pressures applied are necessary, if you have achieved your physiological goals, whether those can be eased out. And look at the desynchrony. You have a lot of patients who have collapsed lungs, and then our respiratory therapies are passed into action. So can we avoid that? Can we prevent that? So if you want to prevent these complications, of course you have to anticipate what are the problems happening. And that's why this comes. When are you going to think of weaning in a patient? I think at the same time you start ventilating. Because you have to understand our support is going to be temporary and it is meant for a reason. So we have to look at that. This was just a breach for temporary reasons. Whenever we find that, most of the times, as madam has told, we had talked of in NIV lecture also, that patient with COPD exacerbations or acute pulmonary edemas, when you put them on NIV, you can take those NIVs off within 12 hours, 16 hours, because you have achieved say bronchodilation with bronchodilator therapies and injectable steroids. If the pulmonary edema is settling, you don't want to continuously keep ventilating these patients, right? So you have to understand that there are certain situations where your supports are no more needed. So there are ICUs which follow daily breathing trials or sedation-free intervals for the same reason, that patient should be on a weaning trial as early as possible. There are, of course, indices to look at, and as the intubation was important, extubation and post-ventilatory care is also an important aspect. So you have to understand these all are the important aspect. So I hope in the next coming 2 or 3 talks you will understand what are the disease-specific ventilation needs, and you should be able to make a judicious use of your different modes and different tools in a ventilatory setting, because ventilation is just not a strategy. It is kind of intervention which gives hopes to patients that yes, despite of their critical condition, they can be saved. Many times it happens in our ICU that elderly people, patients with strokes and other conditions, patients and their relatives tend to lose hope once they are put on ventilator. They are feared of it. But with the precision of understanding of their condition, with the compassion that we will use this tool judiciously, and with the vigilance that complications will not happen and the patients will be no longer on a ventilator when he doesn't need it, we can not only deliver breaths, but we can deliver hope, healing, and a human touch. Thank you.
Thank you, Dr. Nikhil Varghese sir, for such informative session. I would request Dr. Sandeep Agarwal sir to please felicitate Dr. Nikhil Varghese sir. Dr. Sandeep sir. So moving on to the next session, we will learn about specialized approaches in critical care like trauma, obesity, pregnancy, neurology, transpulmonary pressure and esophageal pressure monitoring. For this session, I would like to invite Dr. Saurabh Fartare, currently consultant and intensivist in critical care medicine at Kokilaben Dhirubhai Ambani Hospital, Mumbai. He is highly skilled ECMO specialist. Welcome, Dr. Saurabh sir.
Good morning, everyone. I am Dr. Saurabh Fartare. I am a critical care specialist from Kokilaben Hospital. Today I will be talking about ventilation strategies in not so common but common patients. I think we have ventilator strategies for most of our patients who are undergoing, who have ARDS and have comorbidities like diabetes, blood pressure. But patients who are obese, who are pregnant, who have some trauma, it could be a chest trauma, it could be a neurotrauma. These patients, there are no set guidelines, This is basically we have to tailor-make them. I think all of us use ventilation in most of our practice. I would be talking about these special cases. So, what is the standard principle in patients when you basically ventilate them? First is when you put them on a ventilator. First is to decision making. When do you decide to ventilate this patient? And second is when do you start weaning them? So that is the first real principle. As soon as the what was taught to us, when to decide to intubate and when should we start weaning them. What are the challenges in these patients, especially pregnant, obese patients, trauma patients? Their physiological alterations are there. So these have to be accounted while ventilating these patients. There are not many trials documenting that, so we need to have an individualized approach. We'll be talking about pregnant patients first. What does really happen in pregnant patients? As you know, the physiology, the total lung capacity decreases hardly by 4 to 6%, but the FRC does decrease by 15 to 25%. The tidal volumes, the minute ventilation is increased, basically 20 to 45%, which is a huge number. These are the main reasons we need to concentrate on ventilating pregnant patients. As you know, most of our pregnant patients would have a CO2 which will be low. So they would have some amount of respiratory alkalosis. So patients, pregnant patients who are asthmatic, in these patients whose CO2 is seen to be normal, we need to pick it up early, that these patients could be retaining CO2. So this is why we need to know the physiology of these patients. What are the causes of respiratory failure in pregnant patients? There are numerous, sometimes hypertensive crisis or amniotic fluid embolism, sometimes cardiomyopathy, peripartum, sometimes tocolytics. I think when we have seen them, there are various tocolytics which can cause respiratory failure. So in these patients, we have to be a little watchful. Other cases like venous thromboembolism, cardiovascular disease, status asthmaticus, any exacerbation of bronchial asthma, they can cause it as well. So while ventilating, mechanically ventilating patients who are pregnant, the first priority obviously is to the mother, but also we should think about how not to harm the fetus. So ideally speaking, PO2s of 55 is okay. We can accept saturations of 88% in normal patients, but in pregnant patients, when do you really decide? You know, delaying ventilation is one thing, and doing it early is one thing. So we need to understand when do we really go ahead and ventilate these patients. So any patients whose PO2 is going down, because the PO2 will also be the oxygenate. If you're oxygenating the mother well, the fetus also gets oxygenated. So we have to make sure that when there is hypoxia in mothers, we have to think about going ahead and putting them on the ventilator. You have to find a middle gap on that, because NIVs, as you know, pregnant ladies are more prone for aspiration because of the decreased gastric emptying. One more thing I wanted to highlight here, ki whenever you're ventilating a pregnant lady, their chest wall is either breast or engorged. The intubation becomes really difficult. So a person who's ventilating these patients, who are endotracheally intubating these patients, should be a senior person who should be doing it, because there are chances of difficult airways which can come across. Obesity, it's not exactly same as pregnant, but yes, somewhat similar. In obesity, the FRC is reduced, the expiratory reserve volume is decreased. So these patients, when the FRC in a mildly obese patient decreases by 22%, and in severely obese patients it's almost to the tune of 33%. The compliance of the lung is decreased. It could be because of various reasons, because of the abdominal, abdominal mass, the chest wall, all those parameters. In these patients, mostly we should try to use an NIV. Unless the NIV fails, we should go ahead with ventilation. Earlier, there was a thought, I think when we started our residency, that I'm sorry. I'll just go ahead anyways. In our pregnancy, in our residency, that we should avoid intubation in obese patients. See, whenever it is required, it is required. Okay, the NIV is important, and it can avoid intubations in most of our patients. But if ventilation is required, we should not shy away from them. We should always, whenever a person is on an NIV, we should reevaluate this patient every 4th hourly to understand if this patient's need for ventilation is there, because delaying NIV, prolonged failed NIV trial can worsen this and delay the intubation. What does really happen in obese patients? Obese patients, when they lie down, their FRC further reduces, and when we are planning to ventilate these patients, it becomes difficult because they need to be their reserves, oxygen reserves are less, so they desaturate quite fast. So these patients, if you're planning to intubate them electively, they should be adequately pre-oxygenated. It can be in the form of high flow nasal cannulas, sometimes CPAP as well. As I earlier spoke about, they have a high risk of aspirations, so we have to be watchful in these patients. Weaning in obese patients also can be difficult because most of these patients may not tolerate weaning trials well. They sometimes have post-extubation striders as well. So it is important to use various tools like the lung ultrasound, or sometimes we use pulmonary pressures monitoring with the help of esophageal pressure, which can help us optimize the PEEP in these patients. So all these modalities should be used carefully while weaning the patients. I will come to trauma. Am I going too fast? Are you guys understanding this? Yeah. So I think we get a lot of trauma patients. In these patients, trauma could be of different parts of your body. Sometimes it could be a polytrauma, which could involve multiple parts of your body. So while ventilating patients with trauma, especially to the chest wall, chest trauma, they can have flail chest, a pneumothorax, a bronchopulmonary fistula, pulmonary contusion, tracheobronchial ruptures. In these patients, what do you need to do? First is try to give them adequate analgesia so that they don't hypoventilate, because if they hypoventilate, they have atelectasis, there are secretions which can get retained, and there are chances of pneumonia. So first is to make sure we have adequately given them analgesia. In spite of that, if they are not being able to ventilate, there is retention of CO2s, then in these patients we need to electively ventilate them. Pneumothoraxis, yes, pneumothoraxis normally can be with a chest tube. Especially in patients who are getting ventilated, we recommend that there should be a chest tube in place, because it can lead to a tension pneumothorax. Ventilating these patients is a little difficult. If the ruptures are below the carina, then you will have to use a double lumen tube. We might have to isolate the lungs to ventilate them. With the use of bronchial blockers, we can use that as well. Now, when we are talking about intubating these patients with the chest trauma, you can understand that these patients would be having other injuries as well. So cervical spine stabilization should be the first thing we should be doing in patients who have trauma, irrespective of us knowing this. Now, trauma in abdominal trauma, this can cause, if there is abdominal trauma, there can be increased abdominal pressure, which can basically cause us to hypoventilate, and again the same risk of pneumonia will increase. So in these patients, we need to be careful not to delay intubations. These patients, if they are ventilated early, will make sense, rather than delaying them and they have a large vomit and aspirate. So also at the same time, when you ventilate the patient, it don't have this preconceived notion that every patient who's been ventilated will require a tracheostomy. I think many a times we have seen that patients, our students also would decide, okay, ये patient को तो tracheostomy ही लगेगा. No, I think first securing the airway is important, and after that trying to ventilate and wean them. I think once the patient is settling down, we should give them spontaneous breathing trials every day and see if we can wean them off the ventilator first before thinking about a tracheostomy. I think analgesia could be now, I think pain specialization has improved. So there are a lot of pain specialists available in most of our hospitals. They do bedside blocks as well. You don't need to call the anesthetist all the time, so they can come to the to your ICUs, give them nerve blocks, and adequate analgesia can be maintained. As you can see, sorry for the busy slide. In abdominal trauma, what really happens? The interthoracic pressure increases because of the diaphragm elevation, which is basically the pleural pressures, peak airway pressures, and mean airway pressures are going up. Basically, the respiratory system compliance decreases because of the decrease in lung volumes, the FRC, the pulmonary vascular resistance also goes up. What happens, as I spoke to you, whenever there is a trauma, these patients tend to hypoventilate, so there is hypercarbia, there is decreased oxygenation, there is increase in the intrapulmonary shunts, and there will be a VQ mismatch. So in these patients, we have to be careful when to go ahead and ventilate. There are various surge response which also happen. There are pulmonary infiltrates, pulmonary contusions which happen. So they cause a lot of. There are certain patients who go into ARDS post these. There could be primary and secondary ARDSs. So we have to watch for that as well. Here I would like to notify that if a person with a facial trauma is coming to you all, always have an expert opinion. Also have an anesthetist standby, because airway can really take a person down. If you are not able to ventilate a patient, it can kill the patient. So having having a expert and also having advanced modalities is important. Having a video laryngoscope or bronchoscope sometimes also may help. Mechanical ventilation in normal patients, as you know, we use tidal volumes of 6 to 8 ml per kg of ideal body weight. Now here I would like to say that it's always the ideal body weight, it's not the actual body weight. Sometimes some patients are obese with a weight of 120 kilos. You will not use, I've seen sometimes some students giving 600, 700, which is wrong. We should actually use it according to the ideal body weight. Driving pressure is important. We have seen time and time again that a driving pressure which is below 14 improves the, it decreases the mortality. Prone ventilations in ARDSs have shown some response, and has shown some 16-hour proning trials have shown improved results. If the patient is requiring high FiO2, high PEEP, and the ventilator requirements are high, in these patients we should use short neuromuscular blockage should be used, as they will help us ventilate the patient well. There wouldn't be any ventilator asynchrony. In these patients, we have to make sure that they are not prolonged. You should, once the ventilator requirements are not so high, we should try to spontaneously make them have a spontaneous breathing trials. That has again shown to improve mortalities. In a person with intra-abdominal hypertension, proning is debatable. Some of the patients who have intra-abdominal hypertension with respiratory failures, sometimes it does help. Recruitment maneuvers are really not recommended in these patients. We can use esophageal pressure monitoring devices, which basically helps us to find out the transpulmonary pressures, which will help us to really identify which patients should be given what PEEP. I'll be talking about that later in the talk. If these patients are worsening intra-abdominal pressure patients, if the intra-abdominal hypertension patients are having respiratory failures, there are various adjunct therapies which can be used. Sometimes you can use an ECOR, which is basically a carbon dioxide removal if they are going into CO2 retention. This is only restricted to patients who do not have hypoxia. But if these are not helping, then we eventually go to ECMO supports. ECMO basically would be used in patients who, in spite of us doing everything, you have tried every modality, you have tried prone couple of times, they are not helping. In these patients, you'll be going ahead with ECMO. The first real ECMO was used in a trauma patient with lung contusions who went into ARDS. ECMOs in traumas are well known. Some of the patients can be operated as well on ECMO. Tracheal ruptures, one of the indications for your patients would be putting them on ECMO, because these patients, when they anastomose these sites, the ventilation becomes difficult. So putting them on the ventilator, or if you don't have a ECMO support, you need to have DLTs to ventilate them. So basically, some of the tracheal ruptures, when they come to you and they need the only real therapy is by surgery. That means you have to anastomose it, and if these patients first 48 hours putting them on ECMO post surgery has shown some good results. Why do you need to measure the esophageal pressures? Basically, how do you use it? Basically, it is used like a RT, Ryle's tube. It is the esophageal balloon is in the lower third of the esophagus, where it is inflated, and once it's inflated, you will have to measure you'll see the cardiac oscillations, which will help us measure it. It's with the help of it, basically you'll be able to measure the transpulmonary pressure. Basically the plateau pressure will tell us the pressure of the alveoli. So alveolar pressure minus the esophageal pressure will give us the transpulmonary pressure. These were the trials which really showed that esophageal pressure monitoring will help us, in a big way. But unfortunately, not many institutes are using this. This basically will really improve the ventilation. We will not unnecessarily be giving high peeps in these patients. Weaning would become better. Whenever you're using transpulmonary pressures, ideal PEEP is what is required. Sometimes a person who has a collapsed alveoli, we keep on giving them high PEEPs and high volumes as well. Sometimes you just need to give them higher PEEPs and come down on the volumes. So in these patients, really it will help us in a big way. Lung ultrasound is something which all of us should know, and it's an emerging thing. During our residency, I think we didn't have that much of a lung ultrasound, but lung ultrasound will help us find out a lot of information regarding the lungs, pneumonia, pleural effusions, pneumothoraxes. Earlier we used to wait for, even if we had to put an IBP or pacing, we had to wait for the respiratory technicians to come to us, put the pacing wire, wait, do an X-ray, go down, check the X-ray, and then see the positioning. Later on, it evolved to a digital X-ray. Now lung ultrasound, using an ultrasound will go a long way. So basically, it helps us in weaning as well. Doing a lung ultrasound every day to see if there is a new patch which is forming, if there is any pneumothorax which is happening, will help us in a big way. This is the ABCD approach for patients who are mechanically ventilated using a USG. Airway, basically you need to, as I spoke about, if there is an pneumonia, pneumothorax, pleural effusions, we can find that out with this approach. Below diaphragm, many patients would have weaning failures. There are ascites, liver cell failures. Those patients would have massive ascites, which will cause a splinting effect on the diaphragm, which will basically lead us to have a weaning failure. Many of the cardiac failures patient also, or a RV overload patients also would have weaning failures. So doing a cardiac, bedside, using a USG for cardiac evaluation will also help us. E by E prime is what we really use. E by E prime of more than 10 to 12 is good. If it's less than 8, that's when we really get worried. Diaphragm, any patient who's been ventilated would have some diaphragm issues later on. For long-term ventilation patients, the diaphragm excursion can be assessed on the USG, and also some of the accessory muscles. If there is failure in weaning, USG can be used for that. Thank you.
Thank you, sir. I would like to request Dr. Nikhil Varghese, sir, to please felicitate Dr. Saurabh, sir. I would request Dr. Nikhil Varghese, sir, to please felicitate our chairpersons, Dr. Sangeeta Srivastava.
Thank you, Dr. Saurabh, for the nice and very informative lecture.
Dr. Yogesh Dudi. Moving on to the next session, I would like to invite first the chairpersons, Dr. Nikhil Varghese, sir, Associate Professor in Terna Medical College and Consultant Intensivist, and Dr. Anita Jain, Intensivist at Terna Speciality Hospital. Our next speaker will guide us through the pathophysiology of ventilatory trauma, focusing on the critical issue of patient ventilator dyssynchrony. For this, I would like to invite Dr. Akshay Chalani, sir, Medical Advisor and Lead Critical Care, Apollo Hospital, Navi Mumbai, has been a chairperson, Mumbai ISCCM, Treasurer-elect, National ISCCM. Welcome, sir.
By the time the stage is set, we must thank Akshay sir for taking time. He has been teachers to all of us. Most of us have worked with sir and learned a lot of things in day-to-day ICU practices. It's really good to learn from you, sir, again.
Thank you, Chairperson, and thank you, Dr. Sandeep, for inviting me to talk on this topic, pathophysiology of ventilatory trauma and understanding the mitigating the patient's ventilatory dyssynchrony. When this topic was given, I was thinking really actually, so when we started our critical care courses and post-graduation in critical care, whether suppose you are driving vehicles or you are sitting in the vehicle or you are using some machine, whether that machine will create a problem. The same thing applies, whether the ventilator will create a problem, whether ventilator will create a trauma. So I'll just try to understand few things in the past. In 1744, what happened? There is one gentleman, his name was John Fothergill. So what he did basically, he tried to find, I think he was a medico actually. So in his premises there was a poisoning with the coal actually. So what he did, he tried to study few patients who received respiration. One group of patients received the respiration mouth to mouth, and other patient received some type of ventilator which was probably like this bellows. So at the end of few days, what he discovered actually, those who received this bellows, they had a bad lung or they did not do well. But those patients who received mouth to mouth respiration, so what I mean to say, one thing we are very clear, suppose somebody is giving mouth to mouth respiration, he won't give too much of pressure, he won't give too much of volume. So those who received minimal volume, those who received minimal pressure, they did well. But the patient where some patient probably not highly influential, some patient preferred this bellows and they were ventilated with this bellows and they did miserably bad. So conclusion what he made, more volume, more pressure is a problem. Again, this term respiratory lung was coined in 1967 to describe diffuse alveolar infiltrates and hyaline membrane found on a post-mortem examination. So this study, I don't know whether it is in USA or somewhere. So what they tried to study, they studied a group of patients who were mechanically ventilated for non-lung issues, who were mechanically ventilated for non-pulmonary issues, post-CABG, post-GI surgery, and they did who died. So in that they found that those patients in which even if they had a non-pulmonary issues, suppose they had a CABG, they had a complicated GI surgery, at the end of postmortem, at the end of death, when who did not do well, their lung also showed some inflammation, some fibrosis. So he made a conclusion, yes, possible that ventilator can create injury, ventilator can cause a trauma. So I'll just talk about this ventilator can cause injury. Yes, it can cause a ventilator trauma. The constellation of pulmonary consequences of mechanical ventilation has been termed ventilator induced lung injury. And the end of polio epidemic, they found that by definition polio only the respiratory issue, the lung parenchyma per se was normal, but those who did not do well, who died, also the lung and the postmortem showed there is a inflammation or there is a damage. So when we talk about this ventilator induced trauma, it is either barotrauma, athlete trauma, volume trauma or biotrauma. I'll just talk about this. Basically when there is a alveolar overdistension, it is volume trauma. Transalveolar overpressurization is a barotrauma. And when there is high shear forces from cyclic opening and collapse of the athletic but recruited alveoli, it is a lateral trauma, and inflammation is a biotrauma. Now those who are doing the post graduation, please focus on this. This is the first lung which is a normal, what we are breathing. So this is a normal spontaneous breathing patients. Ultimately, my previous speaker has told, ultimately we want the pressure which is in the transpulmonary pressure, because that will ultimately decide. Marker hai kare? That will decide how you are going to behave. So see this, suppose this is what we are. Our alveolar pressure, we are breathing at spontaneously we are breathing. At the end of inspiration, at the end of inspiration we are talking about, the alveolar pressure is 0. But the pleural pressure is -8. So ultimately, okay, thanks. So ultimately, your transpulmonary pressure is 8. So you just remember this. This is V. Our alveolar pressure is 0. At the end of inspiration, the pulmonary pressure, the pleural pressure is -8. So ultimately, the transpulmonary pressure is 0 minus 8 is +8. 8 centimeter of water. This is normal. So you must have gone across all this ARDS net trial, everything. You see that every time we wanted to maintain the pressure not above 30. If we want the P-plot to pressure above 30, everybody agree on that. It's clear. So we don't want more than 30. If goes more than 30, there is a problem. Now suppose some trumpet player or you see orchestra, somebody just plays a trump. He creates a pressure more than 100, more than 120. Why does not he develop a problem? Why does not he develop a pneumothorax? Any answers? You understood? Normally we breathe, our pressure in the pleura is -8, alveoli is 0. So ultimately the transpulmonary pressure is around 8. It's clear. Now suppose I play a trumpet, my pressure will go around 150 here, 100, 120. Suppose I play very vigorously. Still my lungs are normal, there is no pneumothorax. Why it happen? Anyway, I'll come to that. That is the reason I am here actually. Now you see this is what we are. The normal, and this is patient is completely paralyzed. Normal anesthetized paralyzed patients on mechanical ventilation. His alveolar pressure is 9 centimeter of water. At the same time, the machine, the chest will try to recall that the pulmonary pressure is around 1 centimeter. So 9 minus 1 is around 8 centimeter of water. This patient has a gross ascites, thick. gross ascites, stiff lung. So we need extra pressure to control that. So we give 30 centimeter of water by mechanical ventilation, and the pleura will create around 25 centimeter of pressure. So it will be around 30 minus 25, around 5 centimeter of water. This trumpet I told you, this is alveolar pressure 150, I play a trump. But to counteract that, the pulmonary pressure will be around 140. So ultimately 150 minus 140, around minus 10 centimeter, that is normal. Now the problem is here. Please focus on this, only on A and E. Now this patient, you must have seen, patient on controlled mechanical ventilation, nothing will happen. But suppose you put the pressure on the pressure support, or you put the pressure on the non-invasive ventilation. Your pressure control above PEEP is only 5 or 10. Just assume that 10. Still sometimes you develop pneumothorax. Why? Because what happened here, there is a significant swing in the pleural pressure. Because lungs are bad, because the chest does not recoil properly, because the diaphragm does not go down up properly. So what will happen? You give the pressure support above 10 is around 10 here. You put the patient on the pressure support 10 above PEEP. And still after 24 hours, sometimes the patient develops pneumothorax. He should not develop, na? Because if our logic applies, ultimately pressure 10 unlikely to cause a problem. But why it create a problem? Because of bad lung, because of bad diaphragm, because of the proper lung pathology. What will happen? There is a significant pressure in the pleura, significant negative swing in the pleura. So ultimately this 10 minus 15, which comes to plus 15, it comes around 25 centimeter of water, which transpulmonary pressure is very high. That is the reason that patient develop pneumothorax. It's clear? There is a significant swing in the pleural pressure when the patient is on the spontaneous breathing, when patient on the pressure support breathing. Because of that significant swing, it has to create a negative pressure which will ultimately cause high transpulmonary pressure. That is the reason, in spite of minimal support, in spite of very less support on spontaneous breathing patient or completely awake patient with pressure support, with minimal support, he or she might develop pneumothorax, or he might develop lung issues or lung injury. So ultimately what I mean to say, if it is causing a lung injury, it is causing a pneumothorax, what you need to understand, as Dr. Fadre just now said, don't see only number, plateau pressure. What exactly you need to see, if you are in a 5-star hospital or if everything is given to you, actually you need to check the transpulmonary pressure, and the way to check that is a esophageal pressure. Is it clear? That is the reason that many pressures come into the picture as when we ventilate the ARDS and all that. So what you need to understand now, when you ventilate, this is more problem when the patient is on spontaneous breath, not on the control breath, because the control everything is okay. We told the diaphragm to after 2 minutes or after 2 seconds you need to give inspiration, expiration. Here the problem, when there is a spontaneous breathing, there is a significant swing in the pleural pressure which is negative. Ultimately it will add and create a transpulmonary pressure which is very high, which will cause a lung injury which is called as a barotrauma. It's clear? This is because of pressure. That is the reason that various pressure come into the picture, and now the esophageal pressure is recommended to check when you do ventilate the ARDS. Because it's possible, in third scenario you just see here, you are giving the pressure control about PEEP is around 20, PEEP is 10. Still it is insufficient, because ultimately what pressure is transmitted across the pleura is different because of thick chest wall or ascites or other issues. This is what I try to tell you. This is one, this pressure will create a problem. Second, now then somebody will say, yes, if the pressure is a problem, you give a low tidal volume. It will not create a problem. Will it create a problem? Now you see the ARDS net trial, what they said, don't give too much of volume. It will create a high pressure and it will create a problem. So my question to you, where you give a low tidal volume, whether it will create a problem. We won't allow the pressure to go above 30, it's clear. You give a low tidal volume, 3 ml, 6 ml per kg per body weight, plateau pressure never goes above 30. Will it create a problem? Yes, it will create a problem. Please understand now. It will create a problem in which the lung is inhomogeneous. The lung is uneven. So please remember, I'll just try to explain to you. Now what will happen? So there is one gentleman, I forgot his name. So what he did, he took two animals, two rat. In one rat, he did mechanical ventilation by targeting the tidal volume, and in the second rat, he did mechanical ventilation by target the pressure volume. So what he did actually, pressure control. What he did, in both the rat, the pressure did not go above 30. Plateau pressure, in volume control, the plateau pressure did not go above 30. In the pressure control, the pressure did not allow to go above 30. But in first rat, he created high tidal volume and low peak. In the second rat, he gave high pressure control and same peak. So he found that though the pressures are same, the rat in which he gave the tidal volume is a more problem as compared to the rat in which he gave the high tidal pressure control with high peak. Now why it will happen? So what happened, just focus on this slide. When the lung is inhomogeneous, suppose there is one alveoli here, that alveoli will require around 5 centimeter of water pressure to expand that. But the alveoli which is near to this alveoli, which is normal, suppose you give around 5 centimeter of water pressure to this, that is too much for him, too much for that alveoli. So when there is uneven surface, when there is uneven alveoli in homogeneous lung, the same volume will create a problem. That is one thing. It will create a volume for that normal alveoli because that is too much for him. That may be too less for that distended or that diseased alveoli. That is one thing. And second, when the two alveoli are near together, the same pressure, when these two alveoli interact with each other or they surface each other, that will cause a trauma to the alveolar membrane. That is the reason that low tidal volume, it is not the tidal volume per se, it is a cycling of pressure in between the two alveoli, which is one is normal, second is abnormal, will create a problem, and that will cause the atlectic trauma actually. Is it clear? It happens in the inhomogeneous lung because whatever the pressure, whatever the air you are giving, that air may be very high for a normal lung and that may be very low for the diseased lung. It's clear? So this, you know, the physical forces, regional lung over distension creates high transpulmonary pressure that damage the alveolar, just now we have seen. And the structural damage, epithelial sloughing, hyaline membrane formation, increased vascular permeability and pulmonary edema. I'll just show to you that in the next few slides. This is pretty clear, but when you give a high tidal volume, then this is a normal lung on the left side and the right side there is a hyperinflated lung that will cause a air leak in between. Here you can see that. This is now, what is the consequences of this atlectic trauma and the volume trauma? The more tidal volume you give, the more recycling of the two alveoli, what will happen? Ultimately it will release some inflammatory cytokines. There will be sloughing of the bronchial epithelium, mesenchymal transformation, so it will cause surfactants, interleukin 6, and that will cause a problem, that will cause a biological inflammatory markers. If they are localized, they will cause this pulmonary edema and fibroproliferation, and if they will too high, it will go to the systemic circulation and create a problem. So this is, one is volume, second is atlecticity, and third is a biological trauma. This is what ultimately it will happen. It will cause multiple mechanism. It will cause the cell death, a translocation of lipopolysaccharide bacteria, various mediators. This is in NEGM, you can read this, but ultimately what I mean to say, because of this multiple trauma, there is a release of inflammatory cytokines in the lung. If it is too much, it will go to the system and will create a problem. This is ultimately will cause a multi-organ dysfunction and death. Now the issue is that, is it really important? Once patient on ventilator, it is giving adequate tidal volume, not giving adequate tidal volume. How it will affect the outcome? Yes, it will affect the outcome. How? 30% higher mortality risk associated with the severe dyssynchrony compared to the synchronized ventilation. The studies are clear-cut showed. So you need to synchronize the patient with the ventilator. And average increase in the ICU length of stay due to unrecognized ventilator trauma is around 3 to 5 days. And we know in Indian scenario, per day bill in ICU is more than 1 lakh. So you need to look into this very seriously actually. So what is exactly the patient ventilator dyssynchrony? Is a mismatch between the respiratory drive and the ventilator delivery breath, resulting in ineffective ventilation and the potential lung injury. So what are the ways we can control trigger dyssynchrony? Either it is ineffective or auto trigger. Whichever trigger you use, you will be going through the hands-on, whether you use a flow trigger or whether you use a pressure trigger, you need to know what are the numbers, where to use and what not to use. So given the expert will comment on that, but I really don't know, either you use pressure or either you use a flow, but it is little, I'm comfortable with the flow trigger, whatever you use, but you need to see that the appropriate trigger you have put on the machine. So this is basically ineffective trigger when there is a dysynchrony actually. Here the the flow is generated, here the pressure is generated, but the pressure is insufficient or the flow is insufficient to make the ventilator or to stimulate your diaphragm to take a normal breath. So this is an ineffective triggering. So it may be -1 or -2, you just need to, it may be -5, -6, you need to go to -2 or -3. This is a double triggering, patient triggering basic. The patient is triggering here, this is the pressure, this is the flow. Patient is triggering here, but immediately after within the next breath, it is again double, the machine is triggering. So what you need to see here, either you sedate the patient or either if the patient is too stable, you extubate the patients. This is trigger delay and ineffective triggering. Just now I shown that patient has created a negative pressure, but the machine has not given a breath. So this dotted mark, you can see that the trigger is delayed, and here in spite of triggering there is no effective breathing. Flow dysynchrony, what you see, mismatch between the patient's inspiratory demand and the ventilator flow delivery. Here you can see this is little abnormal. The moment you have a ventilator with the graphs, you can see here actually, this is the flow starvation, this concave, this waveform concave inwards, what you can see, whatever the flow you are giving actually, it's inadequate, or the patient is taking, demand is too high and what you are giving is too less actually. Here you can see just volume starvation, the same thing in the loop actually. Premature or delayed termination of mechanical breath related to the patient's effort. So what exactly cycling means? You are stopping the patient when it is not required, or your patient is still breathing and you are terminating the breath actually. So this is the early cycle and the late cycle. This dotted, this which color is this? Purple color. Here you can see basically this is the early cycle. This machine inspiratory time terminates before the patient's inspiratory time ends actually. This one here, and this is a late cycle. This is machine inspiratory terminates after patient's high time. So patient stop breathing and machine is still giving the breath actually. So basically mode, again I come to that, inappropriate ventilatory mode selection for the patient's respiratory physiology will again create a problem. Most of the ICU, few of the ICU I have seen, once patient is on PRVC, whether he is awake, whether he is not awake, whether he is on muscle paralyzing agent, till somebody extubate, he is always on the PRVC because somebody is comfortable. So please remember, suppose you put the patient on the PRVC, the moment become patient conscious or the moment patient start breathing, it makes sense to convert to the either pressure control or volume control. Don't keep on PRVC. My suggestion is, if the patient is completely paralyzed, severe ARDS, that point of time only PRVC. The moment you think that he is winnable, you need to shift to the control mode. Either is assist control on the pressure or volume control. Don't keep on PRVC, because the moment the pressure trigger on the PRVC, the system goes haywire. Now this is what exactly is the pathophysiology, disruption of the normal feedback loops between the respiratory center and the mechanical supports, diaphragmatic weakness or the over assistance leading to the ventilator induced diaphragmatic dysfunction. Sometimes we see you put the patient on the pressure support 5 or pressure support 10 suppose you put, and then after 2 hours you go, somebody, sister says no, patient is not breathing, so we put on the pressure control. That point of time you just need to see the patient is not breathing, whether he is too comfortable or whether he is not uncomfortable. Most of the time it happens that patient is too comfortable, that is the reason you go into apnea and you put on the pressure control. That doesn't make sense. So what you need to see, the patient on the pressure support and he is going to apnea, there are 2 reasons. That you are giving too much of pressure support to him, that he doesn't work. So it's lazy person. Suppose somebody has a lot of money and you are giving again too money, he won't work. The same thing happens to the pressure support. If the patient is too much comfortable going to apnea mode, doesn't make that you need to put on the pressure control. You see that what the pressure support you are giving is less, then put on TPS and extubate him. What are the ways to follow? You just need to do the patient's assessment, continuous monitoring, ventilator configuration and dynamic adjustment. So every time you just need to see that once you put on pressure on a particular mode, you need to change or decrease or increase the support the way you feel. Mitigation strategies, once you know that there is a ventilator dysynchrony, what exactly you can do? You just need to check the knobs on the ventilator, trigger sensitivity, flow rates or cycling criteria, depends upon the patient's respiratory mechanisms. Sedation every morning around early morning, suppose you go for the rounds at 10 o'clock, 8 o'clock you need to see that you stop the sedation. It doesn't make that, suppose you stop the sedation So I see sometimes patient is on midazolam, patient is on fentanyl. So at 8 o'clock midazolam is stopped, at 10 o'clock fentanyl is decreased, and then 12 o'clock it is stopped. So don't do like this. If the patient is relatively okay, completely stop the sedation and see what is the sensorium. Once you know that this is the sensorium, go back to the sedation if you feel, and don't keep the patient awake on the ventilator. This is what I feel actually. Patient was doing on the pressure support well in the night, or at least you give some rest, because this is very traumatic. If the patient is on mechanical ventilation, tube in your mouth, it is very traumatic. So either you extubate the patient within the 2 hours or go back and sedate the patients, unless and until there are specific indications. But it's very traumatic memory for a patient to remember that he is on mechanical or she is on mechanical ventilations. So if you are not extubating, please sedate the patient, or at least see that he is not completely awake. So you need to stop the sedation once in 24 hours, and don't stop in the evening. Suppose morning 8 o'clock you stop the sedation, you tried for extubation and you are unsuccessful. Don't try again extubation in the night. Generally, by and large, you give 24 hours for the diaphragm to take a rest and muscle to take a rest. So next day morning you try evening. And when you talk about the TP's trial, the name itself is a trial. So don't keep trial for 6 hours, 8 hours and 12 hours. Unless patient has a head injury or something like that. Utilize the patient triggered modes such as pressure support ventilation or neurally adjusted ventilator assist if possible. Now this is a new concept actually, last 2 slides. This new concept has come into the medical term. This is mechanical power basically. We learn in the medical school that energy cannot be destroyed. Suppose I am giving energy to some person, he will go to B, B will go to C, C will go to D. It can't be destroyed. The same thing. When you are ventilating the patient, you are giving some energy. So that energy from the patient will go to from ventilator to go to the patients. So at the same time, whatever energy you are giving, that should not be too much, that not be too less. So there are complex formulas, but I want you to just sensitize you about this mechanical power. So this approach leverages fundamental thermodynamic principles governing the energy transfer to model the energy exchange between the ventilator and the respiratory system on each breath. Last 1 slides, what are the clinical implications? So if you see, there is only clinical diagnosis. Suppose you are doing some calculation for mechanical power, yes, we know you are giving too much. But how do you identify mechanical dyssynchrony between the patient and the ventilator? This is clinical diagnosis. Like malaria, you have a PS for MP, for pneumonia, you have X-ray. But for stress and all that, for anxiety, you don't have. It's clinical diagnosis. The same thing for mechanical ventilation, dyssynchrony, what you need to see, that patient is not comfortable, what ways you can mitigate that or what ways you can cut it down. Integrate the respiratory therapist, intensivist and the nursing staff in daily ventilator management rounds with standardized assessment protocols. Utilize advanced ventilator modes and monitoring system to provide the real-time feedback on patient's ventilator synchrony, and implement the ongoing training program like this, focusing on waveform interpretation and evidence-based ventilator strategies. Thank you. That's all from my side. I'll be happy to answer any questions in case somebody has.
Thank you very much, sir. It was the illustrative talk, and of course, it had many take-home messages for all the intensivists and students as well. If there are any questions,
any questions? Okay. Thank you, sir, for a wonderful speech and taking out time today. Sir, please wait. I would like to request Dr. Sandeep Agarwal, sir, to felicitate Dr. Akshay Chalani, sir.
Those students who are on the back side, please come forward. Come forward to the front rows.
Moving on to the next topic, we all encounter at the bedside, that is mechanical ventilator alarms. So in this session, we will see what these alarms are telling us, why they occur, and how we can respond effectively to ensure patient safety. For this session, I would like to invite Dr. Prashant Zedge. Sir is MD Anesthesiology, IDCCM, Critical Care Medicine Consultant and Intensivist, Professor Department of Critical Care Medicine at Bharati Vidyapit University Medical College, Pune. Welcome, sir.
So I'll try to keep it simple because Dr. Nikhil and Dr. Akshay has already touched both of these topics a bit. So this is an usual scenario in our ICUs because ICUs are quite busy and there are lots of volumes going on, and in particular that the sounds of ventilator, the alarms, they stand out quite often. Decoding these alarms and trying to find out what are the triggers for these alarms and how to troubleshoot these alarms is a vital skill, and we'll try to go through that. Good morning, and how we'll go through is try to learn about the alarms and what triggers it and how to troubleshoot. Quickly, I'll run through the patient ventilator asynchronies, how to identify those asynchronies, troubleshoot, and I'll touch upon the recent advances in both of these things. So these ventilators, they have the sensors. Sensors are the ears and the eyes of the ventilator. So in each ventilator there are flow sensor, pressure sensor, volume sensors, and many times these all sensors, they send the data to the microcontroller of the ventilator, which is like a computer of the ventilator. And this microcontroller compares your measured values and the program limit which you have set. And if these things are not matching, it gives you alarm. If these things are matching, doesn't give alarm. If they are not matching, the alarm will be turned around. So the alarm, it tells the clinician about the deviations from the set parameters, which could be either result into the patient safety or the device malfunction. And as the life has got the priorities, the high priorities and low priorities, even ventilator has got high priority alarms and low priority alarms. But whenever the alarm runs in, don't just run to silence the alarm. Silence only when you understand what is the mechanism of this alarm and you are able to take control over the alarm, the reason for the alarm. So these are the high priority alarm. What are those? Those are the alarm which are immediate threat to the patient safety, particularly apnea alarm, high peak inspiratory pressure alarm, or the disconnection alarm. They are the high priority alarm. And almost all the ventilator, it is shown in the red, and even its beep is different. So it will be just like, it's not running here. The beep will be continuous for the high pressure alarm and it will be high pitch beep. The low priority alarms, they do not pose immediate risk to the patient's life. It could be because of the low battery or higher respiratory rate. You can have some time to tackle these things. And usually it is in the yellow color or blue color, and the beep is also different from the high priority alarm. Again, the manufacturer, accordingly it will change depending upon the ventilator manufacturing. So what are the alarms which we face? It could be either high pressure or high peak or low peak alarm, high tidal volume or low tidal volume, which will again result into the minute ventilation. So it could be high minute ventilation or low minute ventilation alarm, or high or low respiratory rate alarm. Again, it can go through the apnea alarms. So we'll go to these alarm one by one. High PIP alarm. Why we see high PIP alarm and what is the significance of it? Because it tells you about the change in patient condition. Suddenly something has changed, that is why it is given high pressure alarm. If not treated, not given due consideration to that, it can lead to the barotrauma, or because of the safety mechanisms involved in the high pressure alarm, it can lead to the inadequate ventilation and patient will again land up into the low minute ventilation. So this is what is a ventilator graph you might have seen many a times. It's a pressure, flow, volume versus the time on the x-axis, and you have got a pressure limit which you have set. The volumes and the pressure will go till whatever you have set. If it goes above that, the pressure will be cut off, the flows will cut off, and volume delivery will reduce, because ventilator knows that this is the limit, this is the maximum pressure I need to give. If it goes above that, it will stop giving the breath. So the volume, you can see the volume graph, the volumes are dramatically reduced when the high pressure alarm limits are reached. So what are the reasons for high pressure alarm? So it could be ventilator factors, patient factors, and the interface, the components between the patient and the ventilator. So in ventilator, sorry. In ventilator factors, if your flows are very high, it will rise the pressures rapidly, and that is why it can give high pressure alarm. If you have got a short inspiratory time, you have to give the tidal volume in that short inspiratory time, so ventilator gives the flows rapidly. Or if you have an inappropriate settings of the inspiratory high pressure alarms, if your alarms you have set it at the lower level, inadvertently it will give you the high pressure alarm. The interface, that's the component between the patient and the ventilator. If there is tube is kinked or tube is blocked, or the commonest being the HME kept for a couple of days extra, it get condensed with the water and it get blocks, and that can give rise to the high pressure alarm. Patient factors, as Nikhil sir has also described these things nicely. Patient coughing, if there is a bronchospasm or endobronchial intubation. The high pressure alarm because of the decrease in compliance like ARDS, pneumonias, collapse, fibrosis, or pneumothorax. Or if there is an increase in the chest wall resistance like obesity, abdominal distension, if you have tight abdominal dressing or even tight chest dressing, can give rise to high pressure alarm. How do you troubleshoot high pressure alarm? For any troubleshooting, priority is patient. Look at the patient first, then the machine itself. Look for whether patient requires immediate resuscitation. Check for the ABCs quickly. There are two ways by which you can troubleshoot the high pressure alarm. If things are feasible, disconnect the patient from ventilator, connect the tube to the bag, and try to ventilate the patient. Since our priority is patient, we look at the patient factors first. Whether it is difficult to ventilate with the bag. If it is difficult to ventilate, that means the problem is in the patient side. So try to pass the suction catheter beyond the endotracheal tube. If you are able to pass it beyond the endotracheal tube easily, that means the tube is patent. If you are not able to pass, if there is a resistance to passing the suction catheter through the tube, that means tube might be completely or partially blocked. What you need to do, you need to change the tube. If and the problem resolved, you can continue with the ventilation. If you are able to pass the suction catheter, that means the problem is beyond the endotracheal tube, you auscultate. If there is a wheeze, likely reasons would be bronchospasm or pulmonary edema, etc. Auscultatory finding, if the breath sounds are there only on the one side, you try coming down to the diagnosis. It might be endobronchial intubation, unilateral pneumonia, or pneumothorax, and accordingly treat those things. If you are connected to the bag and you are able to ventilate easily, that means the problems are on the machine side. So the machine or the tube side. So check the tubings and the filter. If there is a filter is blocked, you need to change the filters. And on the ventilator side, check the relevant settings, why it is giving you the high pressure alarm, and check the alarm limits. And if the things are not solving, don't waste the time, change the ventilator, use a new ventilator with new settings, and continue with the mechanical ventilation. You can troubleshoot the high pressure alarm by the basic equation of the motion. You might have learned it quite a long time. The airway pressure is flow into resistance plus the alveolar pressure, that is the volume upon compliance. When you make the flow 0, this equation tells you the airway pressure is equal to alveolar pressure, and accordingly, so this can be done by instituting an inspiratory pause. So by doing inspiratory pause, you are stopping the inflow of the gas, so flow becomes 0. Whatever pressure you get after inspiratory pause is your alveolar pressure. So this is normal phenomenon. You give tidal volume, pressure increases, you got a peak pressure and there is a plateau pressure. When the compliance is reduced, the pressure increases and the plateau pressure also increases. This has been taught even yesterday also. So the difference between the peak pressure and the plateau pressure is low. If the pressures are high, that is likely the reason could be decrease in the compliance, like ARDS. And if this difference between the peak pressure and the plateau pressure is large, the increase in the increase in the pressure is contributed by the resistive pattern of the airways. So it could be because of the blockage, it could be because of the spasm. So this way you will be able to zero down on the reason why the peak pressure is high and accordingly treat it. Coming to the next alarm, low peak airway, peak inspiratory pressure. Why it is significant? Because if there is a low peak inspiratory pressure, it tells you there is a leak in the system. And since there is a leak in the system, the volumes will be reduced. And since the volumes are reduced, minute ventilation will be reduced. And if there is a leak, there is a reasons for the desaturation because it can give loss of PEEP or de-recruitment can happen. And it takes a hell lot of time to increase the saturation if there is a de-recruitment, particularly in the areas where you require higher PEEP. So keep a watch on it. The reasons could be endotracheal factors or the ventilator factors. How to troubleshoot that? First and priority, again, the patient is the priority. Watch for desaturation. Check whether patient requires immediate resuscitation. Check for the cuff leak. If there is a cuff leak, because there is an interface between the fluid and the air, there will be gurgling sounds from the oral cavity and cuff pressure, endotracheal tube cuff pressure will be reduced. Look for the tube dislodgement. Check the ETT position which is fixed at the teeth. So previously it was fixed at 24, now it is coming out. So that does tell you that tube has been dislodged and that could be the reason for the low inspiratory pressures. Look for the breathing circuit. Remember one thing, if there are too many connections in between, every connection gives rise to the chances of disconnection. So whenever there are too many connections, there is likely possibility that disconnections will be there and leak will be from there. And the commonest being when you attach the suction catheter, if you see that HME filter has got a knob, it got a screwed thing behind. Sometimes it might be loosened up and that can give rise to the low inspiratory pressure alarms. Commonest being suction catheter, if the valve is incompetent, it will continuously keep on sucking the air from the endotracheal tube and that can give rise to the low pressure alarm. And then you check for your alarm setting. If your alarm settings are not properly set, it can still give rise to low peak inspiratory pressure alarm. Next is high or low tidal volume or minute ventilation alarm. So in all ventilator it may not be available. Some ventilators will have the high or low minute ventilation alarms and low tidal volume alarm. Both carry the same meaning. Sometimes you may need to set the minute ventilation limits. Usually when the normal minute ventilation, you set the limits up and down by almost 20 to 25% of normal limit. High minute ventilation, it tells you there is an increase in the tidal volume or increase in the respiratory rate or both, because it's a product of tidal volume into respiratory rate. The reasons for that could be pain, anxiety, acidosis, distress or inappropriate settings on the ventilatory ventilator side. Again, coming to the low tidal volume alarm, it could be again, it can be because of the leak, and here it could be endotracheal tube cuff leak, or sometimes bronchopleural fistula can give rise to low tidal volume alarms. It could be because of the disconnection and inappropriate volume deliveries. High or low respiratory rate. High rate could be because of the agitation, distress, pain or sometimes auto trigger. We'll come to those asynchronous little later. And lower respiratory rate again can lead to the apnea alarms. Why apnea alarms are important? What it signifies? It signifies the respiratory drive is reduced. The previously patient was on the controlled ventilation, now breathing on its own and suddenly starts breathing. That means the respiratory drive has reduced and it goes to the backup ventilation. The backup ventilation is always there for all the ventilators. The causes could be patient factor, interface factors or the ventilatory settings and the disconnections. How to troubleshoot the apnea alarms? Again, first thing you look at the patient respiratory efforts. This could be due, most oftenly it is because of the decreased respiratory drive. Check for the appropriate backup settings. Sometimes if you set an apnea interval only for 10 seconds, if the patient doesn't breathe in 10 seconds, he will go to the backup mode. So it has to be appropriately set. Change to the mandatory mode if the apnea alarm goes very frequently. Check for the endotracheal tube position. If it is not in position, patient will not breathe through the endotracheal tube, so it will give apnea intervals. Check for the ventilatory settings and the connections. Check for the systemic factors, because here the systemic factors matter so much, particularly neurological status, because head injury patient, sudden compression on the brainstem will reduce the respiratory drive and patient stop breathing. Severe hypoglycemia, or sometimes misadvertently we give the increased sedative agents, or sometimes you inadvertently you give paralyzing agents, the respiratory drive will reduce and that can give rise to high pressure alarm. Always look for the sedation scores and change your sedative strategies accordingly. This was with the alarms, but we need to consider a few things, because alarms are not only ventilator alarms in the ICUs. Your monitors gives alarm, your ventilator, your even dialysis machine sometimes, and there is lots of noise. And that has been found to have a major reason for the delirium in the ICU patient, particularly old age patients. This could be because of the sleep deprivation. Continuously alarm running in the night will reduce the sleep and quality of sleep also. It increases the anxiety in the patient, because they keep on hearing something always is beeping at their ears. Sometimes continuously running alarms, relatives are beside the patient. It inculcates some degree of mistrust on the doctors, because doctors are not there, alarms are running, nobody is looking after that. So you need to adjust your alarm settings accordingly to reduce the alarm. One more thing is there, the alarm fatigue that is been observed in the healthcare worker. If the continuously unnecessarily alarms are there, we switch the alarm, we switch the alarm, and one moment will be there where the alarm will be like an really important, and we will try to miss those alarms. That has been associated with alarm fatigue. We know in Marathi, if you remember, Landga Lare Ala. So some kid has a funny thing, he will keep on telling the false beliefs ki there is a wolf which is coming to the house. The people will gather every time, and one fine day the real wolf comes in and nobody comes for the help. So that can happen with the alarm fatigue. Coming to the next topic, the patient ventilator asynchrony. The asynchrony, as Akshay sir has mentioned, it's a mismatch between patient's demand of the from the ventilator and what ventilator supplies to the patient. So patient's demand could be in terms of time, flow, volumes, or the pressure, and ventilator supplies these things during the mechanical ventilation. And if there is a mismatch in between these two, the asynchrony can happen. Asynchrony is always, in our life also synchrony is important. So asynchrony is always harmful. So this was the asynchrony index was there. So if that is the number of asynchrony events divided by total number of breaths, whether synchronous or asynchronous, into 100. So, and if the asynchrony index is more than 10%, it is associated with higher incidences of worst outcome. So that's an AI. This was generated in some AI machine. How much asynchronies are there? So that was an AI in the AI. Asynchronies, as we know, could be at the various stages of the breath delivery. We know that the basic variables are like trigger. That trigger is how the breath starts. The limit is what regulates the flow during the breath, and the cycle is how the breath ends, how the phases of respiration ends. So asynchronous can be flow asynchronous, trigger asynchronous, flow asynchronous, or cycling asynchronous. We'll try to go through these quickly. The ineffective triggering, like patient is inspiratory effort fails to trigger the ventilator. Patient tries to breathe, but that breathing attempt has not triggered the ventilator to give an assisted breath. So if you see on the graph, that's a pressure, that's a flow, and lower down is diaphragmatic electrical activity. So if you see on the pressure wave, there is a little drop in the pressure that tells the patient has initiated the negative pressure. The flow has increased here, but it has not triggered the ventilator to give the breath. If you see at the diaphragmatic electrical activity, the diaphragm has given the contraction, but it has not been sensed by the ventilator. Normally it should have looked like this dotted line, but since it is not triggered, it will go back to the baseline. So what are the reasons? If you set the trigger threshold too high, trigger threshold is something you tell the ventilator, Baba, if this is the scenario, then consider this is patient's breath, you assist that breath. So we know that the triggers are like pressure trigger and the flow trigger. Commonly used is flow trigger. So if I, for example, if I set a flow trigger of 2 liters per minute, if the patient generates a flow of 2 liters per minute, then only ventilator will sense this is patient's breath. This is what patient is attempting, and then only it will support that breath. If patient generates a flow of 1.5 liter, no, this is not patient breath, so there won't be any support to that breath. The ineffective initiation can happen because of the presence of auto flow. So we know that intrathoracic pressure with the auto PEEP becomes very high, and to generate the flow in the chest, patient has to negate that auto PEEP to 0 and some negative pressure, then only the inspiration will start. And because of that auto PEEP, the breathing can be ineffective. It can be because of the low respiratory drive or the weak inspiratory effort or degree of sedation. So how to troubleshoot that? By reducing the trigger sensitivity. Again, try to find out the cause for ineffective triggering rather than just changing the trigger sensitivity. You can manage the auto PEEP by giving some degree of extrinsic PEEP, so that patient's effort, the work of breathing will be reduced, and you can decrease the sedation. There is something called as auto trigger. You might have seen many times on the ventilator when you give CPR, you compress on the chest, you compress to compress the heart in between the rib and the spine. It gets out some air from the lung outside, and that triggers the ventilator. So it's a mechanical breath delivered without the inspiratory efforts, and the rate will be more than what you have set on the ventilator. And ideally patient trigger breath will be with a negative deflection, because patient has breath inside, so it created negative pressure in the circuit of ventilator. So here you can't see there is any negative deflection. So these are the auto triggers. The reason for that, if you have set the trigger threshold very low, it can give rise to auto trigger, or if there is an air leak from the endotracheal tube cuff or the ventilator circuit, it will keep on giving the auto trigger breaths, or if there is an water or the secretion in the active humidifier chamber, that can give rise to the auto trigger, or cardiac oscillation sometimes in the very thin built patient or when the CPR is going on. How to troubleshoot this? You increase the trigger sensitivity, check for the leaks in the system, and you can drain the condensate from the circuit so that it will not hamper with the triggering. Double trigger, there are two ways of this asynchronous, like double trigger and the reverse trigger. Double trigger is two mechanical breaths are delivered when patient has given a single inspiratory effort. So this is patient initiated breath. So you can see the yellow line, this is a dip in the pressure, that is patient trigger breath, and with this one inspiratory effort, there are two breaths which are delivered. So there are two unassisted breaths without the expiration in between them, or the duration of that expiration. Duration of expiration is very small. It is less than half of the mean inspiratory time. Then we can say it as a double trigger. So ideally, the normal, you can see here in the down bottom, sorry, it's on the one corner. So ideally the expiration should have finished, the dotted line, but during this there is another breath which is patient initiated will fall on, there will be two breaths. The reason for that, because of the inappropriately set cycling criteria, the expiratory trigger sensitivity is set at too high. so that the expiration starts early, expiration finishes early. When patient's neural inspiratory time is longer, patient wants to breathe longer, but ventilator has stopped the giving inspiration. So in that expiratory phase, patient will continue to keep on inspiring. If a pressure support as you have set is very low, or your pressure ramp, the ramp is the flow rate, the pressure rise at which the gases flow inside is very short, in that scenarios there will be double trigger. Or if there is a flow deprivation, the flows which you have set is very low, then there will be double trigger. In the patient side, if the patient's neural inspiratory time is longer than whatever you have set on the ventilator, that will give rise to double trigger. So how to troubleshoot that? By increasing the pressure support, you decrease the expiratory trigger sensitivity. We'll come to those things little later, because those are important things, and many a times we don't set these things on the ventilator. Or you can increase the patient's ventilatory inspiratory time. So how does it work? So you look at the two waveforms, the double trigger, and this is where the expiratory trigger has been set. So this is the point where the expiration starts. So if it's set at too high level, the inspiration will finish early and the expiration will start here. By decreasing the respiratory trigger, you are prolonging the inspiratory time, and that is why the inspiration gets completed, the expiration gets time, and giving the adequate amount of the pressure support. Increasing the pressure support again decreases the expiratory flow trigger and gives an adequate amount of tidal volume. Your inspiration, if shortens down, the tidal volume also gets reduced, and that again leads to the decrease in minute ventilation. Reverse triggering is again something a little different from the double trigger. Here the mechanisms are not yet clear much, but it's a first breath is ventilator delivered breath. The previous one, double trigger, the patient's inspiratory effort, single inspiratory effort gives two respirations, two breaths. Here the first breath is by the ventilator, and since the ventilator delivers the breath, there is an increase in the intrathoracic pressure. It triggers the diaphragmatic contraction, and that is reason why there is a reflex diaphragmatic contraction and the next breath happens. So that is sometimes called as breathtaking, and because of that it will lead to the additional inspiratory effort, and it will cause volume trauma or barotrauma, and it's again the patients are discomfort. So, and the reason for that is because of the stretch receptors are stimulated, it will lead to the reverse triggering. It's a repetitive phenomenon. Sometimes you may see one breath is been given and the other breath comes in immediately. So it can be 1:1 or 1:2 or 1:3. And how to identify, how to differentiate between the reverse triggering and patient's breath is you just do an expiratory hold. So by doing expiratory hold, you are stopping at the end of expiration, and since there is no air remaining, no pressure extra remaining in the lung, the diaphragm will not get contracted. So by doing expiratory hold, if there are no respiratory attempt, that means the previous ones were the reverse trigger. And by doing expiratory hold, if there are still patient effort, that means these are the real patient spontaneous breaths. The reasons for that is sometimes because of the deep sedation, it can give rise to reverse trigger. We see these kind of phenomenon in acute brain injuries quite often. In ARDS, early ARDS, when you are using low tidal volume ventilation, you can see the double trigger. And sometimes when there is a transition from the control ventilation to the assisted ventilation, it can cause a reverse trigger. We need to confirm that and adjust your ventilatory strategies or sedation accordingly to prevent the reverse triggering. So this is just to compare the double trigger versus reverse trigger. We'll just repeat it little quickly. So double trigger, it's a patient generated first breath. You can see there is a negative deflection here, and in the esophageal pressure, if you measure, there is a fall in the esophageal pressure, and this fall continues. So this is a single breath which has triggered two breaths, and in the second breath the pressure increases because there is an active exhalation from the patient here. If esophageal pressures are becoming positive, patient is trying to expire, at the same time there is an inspiration, so the pressure will increase. This is to differentiate from the reverse trigger, which is there is no negative deflection in the pressure waveform. That means it is a machine triggered, machine given breath, and towards the end of inspiration you can see a notch in the flow. That is because of the patient inspiratory effort. And if you see it here, this is a machine trigger because there is no fall in the esophageal pressure at the first breath, and that fall is towards the end of inspiration. Patient's inspiratory attempt is there because we can see there is an esophageal pressure which has been fall. So the simple difference is the double trigger is first breath is machine, first breath is patient driven, and in the reverse triggering the first breath is machine driven, and the mechanism for the double trigger is shorter inspiratory time which is set on the ventilator, while in the reverse triggering the reason for that is because of the stretch of the diaphragm. Stretch receptors are stimulated because of the volume inside the lungs. The flow synchrony is either you have the high flows or the low flows, commonest being the low flows, and it is because of the patient's flow demands are not met with the ventilatory flow demands. How do you identify that? There is an, as Akshay sir has mentioned, there is an scooping in the pressure waveform. Since your flows are inadequate, that esophageal pressures will be very high because patient is trying to take extra effort. So esophageal pressure becomes more negative. Though ideally it should have been like this, the dotted line, but because the flows are inadequate, there will be scooping, concavity facing upward in the flow asynchrony. So what you do is you increase the flows. By increasing the flows, the shape of the pressure waveform gets corrected, but at the same time, by too much of flows are there, because the inspiration becomes faster, the pressure rises, the inspiratory duration becomes smaller, and you can see clearly the esophageal pressures which were more negative has been corrected. The causes of flow asynchrony has become most likely due to inappropriate selection of the ventilatory modes, because in volume control assist mode you need to set the flows either directly or indirectly. In pressure assist control modes, the flows are auto flows. Ventilator decides on patient's demand. So the flow asynchronies are more in the volume control mode, and it tells you about the higher inspiratory drive pressure of the patient. How to troubleshoot that is by increasing the flows, or you can change the mode. Typically required in ARDS, COPD patients, you require higher flows. Cycling asynchrony, Akshay sir already mentioned these things. So we need to consider these two important things. There are two inspiratory time concept, like a neural inspiratory time, patient's own respiratory drive inspiratory time, and the mechanical inspiratory time which you have set on the ventilator. So premature cycling happens, premature patient continues to breathe, his inspiratory time is longer than the mechanical inspiratory time which you have set on the ventilator. And delayed cycling happens when you have set a longer time on the ventilator and patient's inspiratory effort is shorter. So premature cycling, second breath you can identify as a premature cycle. The duration of mechanical breath is shorter than the patient's inspiratory effort. What it increases, it causes increase in work of breathing and inadequacy of the mechanical ventilation. The causes being in the pressure support, you set an ETS, the expiratory trigger sensitivity at very high level, or you give a lower pressure support from the ventilator, it will lead to the premature cycling. And in time cycle ventilation, when you have given a very short time for the inspiration, so it will cause a prematurely shifting from the inspiration to the expiration. The patient, the longer neural inspiratory time is the reason for the premature, I think shorter inspiratory time. How to troubleshoot that? You decrease the expiratory trigger sensitivity, you increase the pressure support, or you increase the inspiratory time on the ventilator so that it will match on the with the patient's inspiratory time. Delayed cycling typically seen in COPD patients because there is a higher airway resistance, and because of that the inspiration is prolonged. There is you need to decrease in the inspiratory flows, but because of the airway resistance, that decrease in the flow is very slow. So it's a prolonged inspiratory flow decrease. Here the duration of mechanical breath is longer than the patient's inspiratory effort. Patient's inspiratory effort has finished, but the ventilator continues to give the inspiration. So what is going to happen? Patient has finished inspiration and will start to expire. At the same time, ventilator is trying to give the inspiration. So towards the end of inspiration, you see the peak. It's like a peaking of the flow, peaking up the pressure towards the end of inspiration. Here it is because of the asynchrony, where your machine continues to give breath, but the ventilator has stopped, the patient has stopped, and rather he is in the expiratory phase. It again increases the work of breathing, and since it prolongs the inspiration, expiration is shortened, and there is a reason for the gas trapping with the delayed cycling. So what is this expiratory trigger sensitivity? So that expiratory trigger sensitivity tells us that inspiration is finished and expiration is started. So most of the ventilators, it's a percentage of the peak inspiratory flow. You set it where you want ventilator to switch from the inspiration to expiration. So imagine a peak inspiratory flow is 40 liters per minute, and you have set an expiratory trigger sensitivity at 25. So 25% of the 40 becomes 10. So when the inspiratory flow reduces to 10%, then it will switch on from the inspiration to the expiration. So if the ETS is high, that means the inspiration will be prolonged, the expiration will be delayed. Okay. So it can be manually set between 5% to 70%. But most of the ventilator, they have the default of around 25%. So you can see it in the lower graph. So when it is peak is 40, it comes to 10, then expiration will start. So if it is like 10% of the flow, that means if the 40 is the peak flow, 40 ka 10% becomes 4, right? So when the flow reaches to the 4 liters per minute, it will switch on to the expiration. So 4 liters of flow will be little down, so inspiration will be prolonged. So this doesn't fit one for all case. So if the ETS is the trigger sensitivity is too low, like 10% or something, the ventilator inspiration will be prolonged, and that will keep on inflating the lungs. Even though patient's neural time is low, patient's own inspiration is finished. And this inspiration, extra inspiratory time, is an passive inspiration, and patient is not participating in that. While if the ETS you have set it at the higher level, like 70%, so when the flow becomes 70% of the peak flow, it will switch on from the inspiration to the expiration. So if the ETS is high, the ventilator will stop delivering the breath early than patient's own inspiratory time, and that might cause damage to the diaphragm, because patient's inspiratory effort is still going on and ventilator has stopped giving the inspiration, and that can lead to the sometimes double trigger or the stack breath, because patient continues to inspire. So this was, I think, okay, change in the font. So this was a short study where they tried to find out what exactly matters when we change the trigger settings. So these were the 10 intubated COPD patients where they check for the delayed cycling or the auto PEEP when they are using the expiratory trigger settings like 10%, 50%, 25% and the 70%. So what they found that as compared to the 10%, when you increase the trigger sensitivity, the inspiration shortens down, you get more time for the expiration, so that reduces the delayed cycling, and that has been significantly reduced the intrinsic PEEP also. That is the reason why in COPD patient you try to keep the expiratory trigger at higher level when there is a gas trapping. So in those scenarios the inspiration will shorten down, you get more time for the expiration, and that has reduced the non-triggering breath also, because auto PEEP is reduced when we know that auto PEEP can give rise to non-trigger breaths. This was a nice review. I just went through how the AI can work into the patient ventilator asynchronies. So it can help you in automatically detecting the asynchronies. So it can predict the chances of weaning failure, and it can optimize the ventilatory strategies accordingly. So there were lots of algorithm like Gaussian effect model or random forest. Even I don't know these things, but they've used, and to my surprise, all these AI models they have found to be very effective in diagnosing with high sensitivity and high specificity, almost 97 to 98% sensitivity specificity to diagnose the types of the patient ventilator asynchronous. So it has got future, and let us see how it works. So to summarize, asynchronous are common, and those are harmful. So we have the trigger flow or cycling asynchrony. You need to have a visual inspection of the waveform to try to identify the asynchrony. Understand patient's underlying disease when you are managing the asynchronies. Before adjusting the ventilator, look at the patient, because that is the key subject here, and avoid deep sedations whenever it is feasible. So all the asynchronies to summarize in one slide. Thank you.
Thank you very much, Prashant sir. I think most of the concept of double triggering and reverse triggering are clear. Yesterday you had questions about this, right? Any questions if you want to ask, this is the time.
Thank you.
Thank you very much.
Thank you, sir. I would like to request Dr. Akshay Chalani, sir, to please felicitate Dr. Prashant, sir. Next, we will be focusing on ARDS, a severe form of respiratory failure, often requiring invasive mechanical ventilation. For this session, I would like to invite Dr. Bharat Jagyasi, sir, Director Critical Care at Kokilaben Dhirubhai Ambani Hospital, Navi Mumbai, Examiner and Teacher at ISCCM, General Secretary ISCCM, and Examination Secretary-elect ISCCM. Welcome, sir.
Again, I must say it's a privilege to chair a session again with Bharat sir, Akshay sir and Bharat sir, both under whom I have worked and learned a lot.
So good morning everyone, and as she introduced, I am Dr. Bharat Jagyasi, Director of Critical Care Department, Kokilaben Hospital. So as it says, it's going to be an evidence-based practice of the ARDS patient, and it's a case-based discussion. I want all of you to come in the front rows, please. Everyone. Front rows. जो पहले आएगा वो सबसे पीछे बैठेगा, जो लास्ट आएगा वो सबसे आगे बैठेगा. Every seat needs to be filled. So you choose your seats. Come faster. अभी जो पीछे हैं वो सब आगे आएंगे. फर्स्ट रो. कम प्लीज. एवरीवन. No, not third row. Come to the second row. And the fourth one, come to the first row. Yeah, fourth row. Come to the first row. No, they are just 4 of them. We have enough. Everyone can be fitted in the first row as well. Please come ahead. So all are critical care students or the SR, CRs of the medical college as well? Okay. So we'll talk about the ARDS, and when we speak about the ARDS, it's mostly we know the term has evolved in many times. In 1967, 12th of August, Ashbrook was the one who found in postmortem patients of 12 patients, where in postmortem of the 12 patients where there was a change in the hyaline membrane of the lung, and this is why he realized that something happens because of the ventilator, and this is the term came in at that time. It was called as a acute lung injury. Then there was a consensus in 1993, then again 97, and the Berlin definition come in, and now we have the global definition. The terminology has evolved from the barotrauma to volute trauma to athlete trauma, and again finally the ergo trauma, and we are still evolving. So this is how the membrane looks like. So these are the two pictures where one is it was ventilated at 45 centimeter of water for 5 minutes, and the next picture it was ventilated at the same pressure for the 20 minutes. So if you could see the difference, initially the basement membrane is just getting disrupted, blebs are formed, and the next there are hemorrhages totally out of the basement membrane is gone. So this is what the ventilator does when you ventilate patient at that higher pressure. And this was that was microscopically, this is macroscopically. So normal lung ventilated at the same pressure, that is 45 centimeter of 5 lungs, followed by at 5 minutes, followed by 45 centimeter of water at 20 minutes. This is how the lung becomes if we continue ventilating patients for that higher pressure. So this is why we need to be very careful, because ARDS is a mechanism where already the lungs are injured because of, it could be anything, and we don't want to suffer them more. So we need to be very casual, and we need to be very sophisticated in treating them. So this is the first case, which is a 42-year-old male and with smoke, non-smoker, comorbidities, and the CT scan, that is HRCT, high resolution CT, shows bilateral ground glass opacity, and ABG is PO2 is 58, FiO2 0.28. So what is PF ratio exactly? How do you calculate it? What is PF ratio? PO2 by FiO2. So do you have any idea, any one of you, how do you classify ARDS? Mild, moderate, severe. Excellent. Yeah. So this is PF ratio of 276. So what is it? This is mild. So now we talk about the definition of ARDS. When do you call it ARDS? So this was basically, the domains have been taken from, this was the latest guideline which has come from the ESICM in 2023. It's been almost 2 years now, but after this nothing is coming. So they worked upon these 9 domains. So they identified 3 areas. That was, one was the phenotype, second was the ventilator strategies, and third was the pharmacological studies. So they answered around 21 recommendations, and 9 domains they worked on. So with the first domain was also on the definition. So what they spoke about is, of course, what we've been following is the Berlin definition, that is 2012, and it has 4 components in it. One is the acute onset. So injury needs to be there within 1 week of the clinical inset. Why is 1 week? Why not 2 weeks, 3 weeks, 10 days? Anyone else? She can't be the one. Anyone else? So basically, it comes from the, what it's called acute ARDS. So suppose if I extend it to 20 days, 21 days, it could be something else. It could be COPD patient who's landed up in. So it has to be the acute event which has happened just recently, and because of that event, patient has become breathless. And again, the bilateral opacities on chest imaging. So it cannot be the unifocal thing. It cannot be an isolated pneumonia. It cannot be a lobar pneumonia. It cannot be a collapse. It cannot be a tumor. It has to be the systemic disease which is causing this clinical syndrome rather than per se lung disease also. And the respiratory failure shouldn't be explained by the fluid overload and the cardiogenic edema. So whenever there is a fluid overload or the right heart failure or the cardiogenic edema, at that moment also you see the bilateral shadows. Patient will be acutely breathless. So that might fit into the ARDS definition if I don't have to exclude this. So of course that part is not required, because that is a disease which is because of cardiac failure, and eventually if we treat our fluid overload, if we get the fluid out of the patient, the cardiac failure gets better, the disease eventually gets better. And the PF ratio, it needs to be less than 300, and accordingly, as she very well defined, the class is being classified as mild, moderate and severe. So mild is when the PF ratio is 200, 300, moderate is 100 to 200, and severe is less than 100. Understood? Understood everyone? Remember this, I'll come back on this and ask you the questions. So now the problem with that definition was, basically when the ESICM underwent. So the problem with that definition, of course, timing wasn't an issue over there, but it showed of imaging and the CT scan. But nowadays we use lots of the USG as well, and we see the B lines, we see the characteristics, bilateral consolidation. So in the newer definition, they included the USG as well. Now the oxygenation PF ratio, of course, in our setup we have the facility of doing ABG again and again and finding out the PF ratio, but it's not possible in various tier 3 cities. Even the tier 2 has it, because India is also, as we call it, is two Indias. One is extreme in better India where we stay in. When you go to the rural, it's a total different condition altogether. You will not even find a machine to do CBC, forget about the ABG. So they came up with the SPO to FiO2 ratio, which is taken from the Kigali modification of the definition. So eventually, as per that definition also, they classified, as per the SPO to FiO2 ratio, they classified mild, moderate and severe ARDS. So there are very pros and cons of it. We'll not go into those discussion. Again, it's about the PEEP. So eventually, if you look at the Berlin definition, patient needs to be on PEEP of more than 5 centimeters. So someone who's not been ventilated, and that patient will not be called, defined as an ARDS patient as per the Berlin definition, as per the Berlin criteria, because of course one of the criteria said there has to be PEEP which is more than 5 centimeters. So that would be possible only if the patient is ventilated. So someone who was not ventilated, you cannot call that patient as an ARDS patient, and this is the reason why they also included HFNO in some settings, and in very resource limited setting they have said even you can avoid the HFNO as well, but though there's a rider to it. And this is the reason why they are also thinking of adding on to is how long the syndrome should go on. That has not been decided, but eventually in the future definitions that will come in. The reason being is sometimes some problems are included as ARDS. We define that disease as an ARDS, but eventually they improve in next 24-48 hours. So what they say is the ARDS is a syndrome. It cannot be something which improves in next 24 hours or 48 hours. It has to last little longer than that. So they are working on that. Maybe it will come up 48 hours, 72 hours or 7 days. It has to continue for that long to define it as an ARDS. Now the static lung compliance is not included, risk factors are not included, and the severity, as I told you, has been classified as mild. So this is what the definition differences in between the Berlin definition and the new global definition. So as per the Berlin definition, she very rightly said this patient had the ARDS and it was mild category ARDS. Everyone agrees with it? Okay. So what is the management consideration we look into? It's a heterogeneous disease, so it's a non-homogeneous lung involvement, because as I told you, it cannot be the one area of the lung which has been involved, it's the whole of both of the lungs are to be involved. It's a variable regional compliance varies in different areas altogether, and of course the risk of Willi is very high, because in the normal lung, as we saw, if you ventilate patient at the higher pressures, the lung gets destroyed, but this is already a damaged lung. If you ventilate this patient beyond certain pressure, it's not going to do well, you'll do more harm than treating the patient. So the key managements here are the appropriate PEEP, lung protective ventilation, minimizing the driving pressure, ultimately leads to the mechanical power. So you have to get down the pressures down so that you do not damage the lung further, which is already suffering. So phenotype will not discuss because that is not part of this, but what will come to is the high flow nasal cannula and the nasal. So whenever it's a mild ARDS, that is the criteria we can consider using HFNC and the NIV as per the certain criteria. So when the ESICM looked into it, so when they compared HFNO versus NIV, what they found is, though in Florale trial HFNO is known to decrease the rate of intubation when compared with NIV. So when you use HFNO in place of NIV in mild ARDS, it will decrease the incidence of intubation, but eventually the mortality remained the same. It did not change the mortality, because the same number of P significance wasn't there in the number of patients treated. So what this suggests is either you use HF, even though there is a trend towards the benefit of the HFNC, but it's not very sure about, because it doesn't prevent the mortality. That rate remains very high. So you can either use HFNO or the NIV in the mild ARDS cases, though we have the, if you could see, we have the benefit of the intubation in the HFNO case. So long-term functional outcome are that are missing, because HFNO we just started using mostly in the COVID era. It was being used, but the majority of the cases came in over here. We don't have very exact good criteria, though we follow the HECOS score and all, but still we don't know how long to continue the HFNO and when to stop it, and this is why we need to have the future trial of the HFNO versus NIV. Now when you use NIV, what they think of NIV is BiPAP. So it's not about the CPAP. Though in what we use in non-invasive ventilation, we have the mode called CPAP as well. We all call it as a NIV. But when they talk about NIV, it's always a BiPAP. It's a bi-level. When you use PEEP versus the IPAP and EPAP. CPAP is a continuous positive air pressure. I think that has been taught to you. So they compared NIV versus CPAP, that is CPAP versus BiPAP. And what is the recommendation? There's no change in the mortality and it's a moderate level of evidence. But for the intubation, of course, NIV was better when it was compared to the CPAP. So panel was unable to make the recommendation over there when it comes to the mortality. But intubation, of course, NIV is better. They also check the helmet because they are being using more and more of the helmet. So helmet is one of the interface which is being used for the NIV. So it's showing some trend towards a better improvement if the patient tolerates it very well. Only the issue is there's evidences of claustrophobia. But as of now, they have not given any recommendation on that. But they have mentioned the helmet for the first time in their guidelines. The helmet being used and helmet being also been mentioned in the guidelines. But the recommendations are not in favor. They said, though we see the trend, but as of now we cannot recommend because the numbers are very less. So non-invasive ventilation may be attempted in the mild ARDS, though the Florali trial showed superior to NIV in reducing the intubation, but there wasn't a mortality benefit. So the potential benefit would be it avoids intubation related complications, it preserves airway defense mechanism because patient's mouth is very clear, they can talk very well, they can cough it out. So in a way it's better than NIV as far as compliance is comfort, as far as the compliance is concerned and the comfort of the patient is concerned. And also it maintains the patient communication because in the mask, that is oronasal mask what we use, patient won't be able to speak, but here patient can speak very well. But the failure predictors, we need to be very rigid in that. We have to monitor it 1 hour. If the HECOS score is more than 5 at 1 hour, you think this patient is not doing well, switch your therapy either to NIV or to the intubation. And the PF ratio less than 200, especially less than 150, you cannot give a trial of NIV. Of course, you can monitor the ROX index as well and the high Apache score as well. So these are the failure predictors where you look into it. When the HECOS score is more than 5 at 1 hour, PF ratio is less than 150, ROX index is less than 4.8 and Apache is in the critically value more than 8 to 10, you do not consider an NIV or HFNC in those patients. And do not delay intubation only because you want to continue. The moment you feel these criteria are not fulfilled, your patient is not doing well, switch to intubation whenever possible. So early is when you given enough trial, your patient is mild ARDS and you are very sure your trial is not working, switch to intubation. That is what the early is. So this patient started on HFNC and NIV trial intermittently and monitoring for the worsening oxygen. So this is what the ABG came in and the PF ratio went down to 92. So what kind of ARDS is it now? It falls into the severe category. So what do we do now? It's progression to severe category actually. It's not moderate. So management of the patient is now have to be ventilation. So this patient will need an oxygen support. Of course, the management of ARDS is oxygen support. Either we go with the HFNC or the NIV. But now since it was a mild case, we tried NIV HFNC. It has worsened to the severe category or the moderate category and now this patient will go for the intubation with the mechanical ventilation. So here comes the fifth domain. We talk about the tidal volume settings in this. So of course you have intubated this patient and there's something called as protective lung strategy which is known as open lung approach. So this is the standard of care of patients in ARDS. In fact, in this recommendation I'll come into, the study which is being done, we'll talk about it. So this is a lower tidal volume ventilation which is frequently done in the ARDS patient and what we face is the problem is hypercapnia. So we have to accept that hypercapnia at certain levels and we'll see how do we do it. And this has come from this trial which was published in NEGM in 2000, which found 6 ml versus 12 ml. So what they compared is 6 ml versus 12 ml. So they found out 6 ml was of course better. But we don't know what is 6 ml versus 8 ml, what is 8 ml versus 10 ml. We are still not very sure about that. So but what they said is because this trial is so robust and now this has become standard of care, ethically it will not be possible to do the further investigations on this to try a patient at the 8 ml and 10 ml because everyone has seen this works. So they won't even get an ethics clearance to try something beyond this level. They can try something less than this but not beyond this level, and this is why though the evidence is now only it's the one trial. So that way evidence is not very robust. Though it's a very good trial but it's only one trial. So they find it evidence as in moderate, but of course they will continue with this recommendation because ethically it's not possible to go ahead and do something else. So what AIRWAY trial evidence showed is there was 9.9% absolute reduction in the mortality when the tidal volume was practiced, that is 6 ml versus 12, and the plateau pressure was maintained less than 30 centimeter of water. So it was a strong recommendation based on expert opinion, though the evidence was moderate. So experts said, no, it's strong, it works, we will not go further and we'll go ahead with the recommendations. So how has been practiced? It's calculated as per the predicted body weight, not the real body weight of the patient. So the predicted body weight formula varies in the males and females. And the target volume could be 4 to 8 ml, average is 6. We have to tolerate the permissive hypercapnia and we have to look into the sedation protocol. So how do we practice it? So if you look into the part 1, you calculate the predicted body weight of the patient. Set a ventilator mode at around 8 ml per kilogram of the predicted body weight. See how the patient behaves. Then reduce by 1 ml per kilogram at intervals of 12 hours till you reach 6 ml per kilogram predicted body weight. Now you set a rate, but do not go respiratory rate, but do not go beyond 35, and see how your carbon dioxide works and how your plateau pressure works. So if your I'll come to the next chart. If the plateau pressure is more than 30, decrease tidal volume by 1 milligram and minimum could be 4 ml per kilogram. If the plateau pressure is less than 25, you can increase your tidal volume by, can I have water please? You can increase your tidal volume by 1 ml per kilogram until your plateau pressures are more than 25. So start at 8, decrease hourly or 2 hourly by 1 till you reach 6. At 6, if your plateau pressures are more than 30, come down further, not less than 4. If your plateau pressure is less than 25, go further up, not more than 8. Clear? So let's revise it. Now patient is come to you with a mild ARDS. What would you do first? HFNC or NIV as well in certain cases. If patient is doing well, and when patient is on HFNC and NIV, what do we monitor? ROX index, ACASCO, Apache and the PF. So you monitor every hourly or 2 hourly. If your patient is doing well, continue. If not doing well, switch the modality. If it was HFNC, you can try NIV or you can go for the intubation straight away, depending how the patient is behaving. If it's a respiration, oxygenation is a problem, or the work of breathing is a problem, then accordingly you can try. Once you intubated the patient, then what kind of ventilation? Low tidal volume ventilation, open lung approach. And how do we do it? With this chart. Now since when we start with the intubation, this was about the tidal volume. What mode would we be using? Anyone? Guess? All guess would be right, huh? What mode is PRVC? Is a volume control or pressure control? There are two basic modes, volume control or pressure control. So volume control or pressure control? Huh? So, it's a huh? It's a pressure regulated volume control. Actually, it's a pressure control mode where the volume is fixed. So, when it comes to the studies, both modes are okay, volume control or the pressure control mode, whichever you can use. But you need to know what needs to be monitored. Here, volume control is preferred for the certain reason because we need to monitor the plateau pressure. So, if you are using a pressure control mode, if the lung gets tightened, what will happen? Your volume will go down. Lung is rigid. For certain 400 ml, we were requiring a pressure of 300. Now, if I fix the pressure control of 30, supposedly. So, to achieve the 30, I was delivering a volume of 400. Now, the lung is become very tight. What will happen? To achieve the 30, only 300, with the tidal volume of 300, 30 will be achieved. So, eventually, it will be a hypoventilation. And all this is calculations as per the volumes. So it's very easy and convenient to go with the volume control mode, but when it comes to the comparison to the mortality, both modes are okay. Okay, and now when you're in volume control mode, you have, because you know it's a fixed volume, so pressures will, if the lung gets tightened, what will happen? Pressures will go up. And here we are trained to monitor the pressures. So as per this criteria, it's convenient and easy to understand the volume control mode. This is how we practice the volume control mode in the patients, and we practice PRVC more often because PRVC has dual advantage. It gives you the desired fixed volume, which is what is required over here, and also it gives the nuances of the pressure control mode, which are more physiological. So of course we decide about the mode, we decide about the volume. Now we have to talk about PEEP. So how do we decide about the PEEP? Any idea? So see, there's a various ways of doing it, but this gives you the PEEP chart. If you can see, there are lower PEEP chart and higher PEEP chart. That is corresponding to the FiO2. So whatever FiO2 your patient is on, as per this chart, either you follow the lower PEEP chart or you follow the higher PEEP chart. You decide which PEEP is to be given. This is the simplest way out. Now to decide about the lower PEEP chart or the higher PEEP chart, how will you choose it? Huh? Lung is affected homogeneously. Sorry. Feel free to answer, don't worry about it. I'm not going to pull you off for this. Mic thing है क्या?
Whether the lung is homogeneously affected or not, we have to
So
see.
usually ARDS lung can't be homogeneous, it has to be heterogeneous. If you talk about the live trial also, which conducted precision medicine versus the personalized medicine versus the protocolized medicine. So what they found is there was actually no difference when it was a personalized care, but when they sub-analyzed it in subgroup, they found the patient who had the homogeneous lung disease, focal area was involved, maybe the lower zone or the one lung, and there if he practiced low tidal volume ventilation, they had more harm. So in fact those are not a category of ARDS patient what you are looking for. Again, that was a bilateral thing. So ARDS what we look for is mostly in heterogeneous disease, not the homogeneous disease. So these are the trials. I'll come to the answer which mode. So these are the trials. So basically initially it was an alveolar trial which came out in 2004 in NEGM, and again they compared higher PEEP versus the lower PEEP, and what they looked into was mortality. So they didn't find any significant difference in the mortality whether we use the high PEEP chart or the low PEEP chart. Again there was a laws which was published in JAMA which looked into the moderate to severe ARDS. Again they did not find any difference in the mortality. Same came out to be true with the Express, which did not find higher PEEP any having more ventilator free days, because they included ventilator free days as well, because the initial chart did not find any difference in the mortality. But when you do the brief meta-analysis of all these three trials, which was published in 2010, what they found is in moderate to severe ARDS patients, high PEEP was beneficial. But when you compare the overall cohort, there is no difference in between the high PEEP and low PEEP. So of course, recommendations over here are by ASICM is they do not give any recommendation whether you practice high PEEP or the lower PEEP as per the guidelines. They say you pick up anything. But when you go to the individual papers, meta-analysis, higher PEEP is to be used when it's a moderate to severe ARDS. Otherwise, it doesn't make any difference in any of the cases. But the guidelines tells you use either of it. You both says you are right. Got this? So now there are various methods to look into the PEEP. Now if you don't want to follow that chart, you want to find how exactly the PEEP is, so there are various methods to do it. So the best is when we look into the PV loop. So there's a lower inflection point and the upper inflection point. हो गया क्या loops का? Talk हो गया? Oh, yesterday. So lower inflection point and upper inflection point. So PEEP is just lower inflection point से ऊपर 1+1+2 is the optimum PEEP. And the upper inflection point is जहाँ के beyond distension होता है, you have to get the plateau pressures below that point. That is one of the method. Or you follow this chart, or you do the esophageal manometry. That will tell you the appropriate PEEP. Again, there's something called as novel approach by the Giacomo Grasselli, which will tell you the recruitment to inflation ratio. Recently, just 15 days back, it was published. PEEP as per the driving pressure, but that was true in the non-ARDS patient. Again, there are some methods where we do the compliance, we'll do the CT scan and find out the appropriate PEEP. We do the sonography of the patient and find the appropriate PEEP. So there are various methods to look into the PEEP, but the easiest one is to follow the chart. These are also the easier one, esophageal manometry, driving pressure. You know how to do it. It's not a rocket science. It can be easily done. So the chart is a standardized method, or we can use a stress. If the loops were taught, if the stress index was taught, even where you achieve the linear portion, that is a stress index of 1, that is also an optimal PEEP. Esophageal manometry or the EIT as well. So there is a machine of few company which will tell you the electrical impedance tomography. You go up on the PEEP, eventually you will see beyond the certain PEEP there is no further improvement in the imaging, and that is the optimum PEEP. Yeah, so this is the lower inflection point and the upper inflection point. The PEEP is just 2 above the upper inflection point, and the plateau pressure is less than, needs to be less than the upper inflection point. Now the recruitment manuals. So we do PEEP, a patient is hypoxic. Do we have, anyone of you practice recruitment manuals? Anyone? So you don't practice recruitment manuals. So basically the guidelines also says not to be routinely practiced. So straight away avoid routine recruitment manuals. So you do not, your patient is hypoxemic, straight away do not recruit your patients. But we used to do it very often. In our teaching days, every patient was hypoxic, the first step was to go and recruit. It was very stylish, as now the sonography is, whatever happens, you pick up the probe and look for it. In our days, it was a recruitment manual. We used to feel very proud while recruiting the patient. And we talk about it and boast about it. Yesterday, I recruited the patient. But that was very routine. Someone who's hypoxic, I have given high PEEP, not improving, I'll go and recruit the patient. And slowly, I'll come down on the PEEP, that is decremental PEEP, and see how the patient is behaving. But the ART trial, which came in 2017, they said with the recruitment, mortality is very high. There were sudden deaths, there were barotrauma. Many more ICDs were put. In fact, this trial was stopped early because mortality is very high. And as for this trial, they realized, and even though the meta-analysis was done, no benefit was found. So they realized routine recruitment manual is not required. So what does it mean? Where do you recruit the patient? So panel recommended not to follow. So there are 2 types of recruitment manual. Brief, when you do a recruitment less than 1 minute, and there's something called as prolonged recruitment when you do a recruitment more than 1 minute. So in both the categories, they have not recommended. Even the brief less than 1 minute is not recommended by the ASICM. So consider, this is not as per the guideline. These are different studies. So they said do not practice routinely. So what does it mean? When do we practice it? So there's something called as RI ratio, that is recruitment inflation ratio, where you can find out the ideal PEEP as well, and also the recruitability. So what exactly happens over there is, sorry, this is very busy chart, so I'll tell you. So there's a patient who's on PEEP of 10, and at the end expiration you see the VT is around 350. So you observe that, and now you know when it's changing from expiration to inspiration. At the end of expiration, from the 10 straight away make a PEEP of 5. So what has happened, since you made a PEEP of from 10 to 5, there will be some de-recruitment. So some extra volume will come in. So initially at the end of expiration, the volume was around 360, VT was 360 or 370. Moment I decrease the PEEP from 10 to 5, that volume will increase by 10 or 20 because a sudden de-recruitment happened and volume will go up. So the difference in the volume with some calculation will gives the RI ratio. So if the recruitability, if the RI ratio is more than 0.5, that means your patient is recruitable. You can try recruitability in those patients. If RI is less than 0.5, that means you do not do recruitability for those patients. Do not recruit those patients. So this was about the PEEP and recruitment, understood? So we went from HFNC, NIV, intubation to low tidal volume ventilation, deciding about the PEEP and recruitment whether needs to be done or not. Then there's something called as driving pressure, which is the difference between the plateau pressure and the PEEP pressure, which represents the stress to the lungs. So this is again come from the Amato. In NEGM it was published. So what you can see over here. So if you see the first diagram over here. See the first one. The PEEP is constant, and as the patient is worsening, the plateau pressure is going up. So the difference between the plateau pressure and the PEEP is increasing, and the lower diagram is about the mortality. So as the difference between the PEEP and plateau pressure is increasing, that is, as the driving pressure is increasing, mortality goes up. In the second one, if you could see, the plateau pressure is increasing because the lung is worsening, but at the same moment they are going up on the PEEP as well. So the constant driving pressure is maintained. Got this? As the patient was worsened, plateau pressures are going up, the PEEP is also gone up, and the constant driving pressure is maintained. If the driving pressure was constant, you can see the mortality was constant. In the third chart, if you see, there is a stable patient where plateau pressures are constant, but they've gone up on the PEEP. So as a result, driving pressure has come down and the mortality has come down. So this was a retrospective analysis of the many more studies where they found a relation, secondary analysis of around 3,500 patients, where they found the driving pressure was associated with mortality. So ventilation was not driving pressure based, but when they went back and see, they saw whenever the driving pressure was going up, the patient died, and whenever the driving pressure came down, patient survived. So they realized we could titrate the PEEP by looking at the driving pressures as well. So that is one of the methodology. So this is why what happened. If you see the same here, the driving pressure of 14, the driving pressure of 35, and the driving pressure of 45, the lung macroscopically gets damaged more and more. And if you see, as the driving pressure goes up, the mortality goes up. So beyond the driving pressure is the one thing, that is plateau pressure. But what we also use is, as also Prashant was talking about, flow rate, frequency, strain rate. So everything in compile is called as mechanical power. So what comes in, supposedly I hit someone with a Newton of 5 joules, power of 5 joules, and I hit the same person 10 times with the power of 5 joules. So what is going to be the effect? 10 times is going to damage more. So if you, mechanical power is, you are ventilating a lung with the plateau pressure, what you achieve is somewhere around 30. So if you keep the rate of 15 and if you keep the rate of 30, with the rate of 30 per minute, obviously you are going to have more damage. So it's not only about the pressure, it's also about the rate, it's also about the flow. If your flow is faster, that means you're achieving that thing for a longer duration. Those pressures remains in the longer duration, and eventually that will also harm the lungs more. So it's not only the one thing, it's the overall circumstances what we look into, and that is what is called as mechanical power. So it is elastance, resistance, and the constant PEEP. So eventually what the, I'll not go into the details of this. So eventually what we acquire is this equation, mechanical power, that is 0.08 into RR into VT, and the bracket we have PP minus half. So this, and many of the ventilators can calculate and give it to you. So what it tells you is, respiratory rate has a linear effect on the power as well. Same is true with the tidal volume, same is also true with the driving pressure, same is also true with the flow rate. So it's not only about the plateau pressure, it's also about the respiratory rate. So whenever you're ventilating the pressure, keep your flow rate to the minimum as the patient is synchronized and stable. Keep your respiratory rate to minimum as the hypercapnia is accepted, and also the tidal volume we are practicing. So if the mechanical power is maintained somewhere around 7 to 12 joules, that is where the outcomes are best. So now, despite of all this, we decided there was this patient had the PF ratio moderate. Now further is gone down to 116. So you have tried HFNC, you have tried NIV, you have done the low volume ventilation, low tidal volume ventilation with the appropriate P, with whichever method you found out. Recruitment maneuver decided to be given or not. You maintain the driving pressure, but still your patient is not doing well. Now what is next? So this is again severe, it will come to the severe ARDS when it goes then less than 100. What is next? Prone positioning. So prone positioning is the one. First we talk about the physiological benefits. Why? What it does is it improves ventilation perfusion matching. It's more homogeneous distribution of ventilation. Reduces dorsal lung compression, better drainage of secretion, and of course reduces the incidence of villi. So it's come from the ProSeva trial evidence where they studied around 450 patients, prone versus supine, and the minimum proning what was used was 16 plus hours. So minimum was 16 and average was 18, but there was nothing less than 16. What they found was 16% absolute reduction in the mortality. In the tidal volume, if you could see low tidal volume, the mortality reduction was 9%. Here is 16%. So this is better than the low tidal volume ventilation. So this has also now become a standard of care when it comes to ventilating the ARDS patient. So when do we do it? We need to select the patient. The movement, it's also been defined in the study. Movement, the patient has PF ratio less than 150, the FiO2 of more than 60% or 0.6, and the PEEP more than 5. That is the time you consider making those patients prone. So if you have a patient whose FiO2 is more than 60 or 60, whose PEEP is more than 5 and the PF ratio is less than 50, those are the candidates where you have to prone the patient. And you intubate the patient. So intubated the patient, and this is the area, or do it early. Early means what? If you achieve these criteria and your patient is stable enough, you put in lines, you started adequate vasopressors, you feel everything has been done, you watch the patient for an hour or so, and then immediately switch to the, if your targets are less than this, if EF ratio less than that, immediately you prone the patient. So it needs a preparation, needs a coordination, and also it needs a monitoring. So even institute needs to be trained with this, but it's not a very rocket. If you do it for 2-3 times, you learn over it. So again, evidence is very strongly in favor of proning, depending on the ProSeva trial. Also the timing, as I told you, but how long? It is minimum to be 16 hours. Beyond it, when to stop it, those studies are not being done. So as of now, minimum 16 hours, but we sometimes practice 24, 36 hours as well, depending how the patient is behaving and how the patient is. There is no evidence for it, and more studies is needed when to stop it, but not less than 16 hours. If you do less than 16 hours, then it's not effective. So now once you're done the proning, about the neuromuscular blockage, so what the evidence is, so we had 2 trials, Accurus trial and the ROSE trial. So Accurus trial, to start with, they used the cis atracurum and atracurum in the patient. They found out the patient who were routinely on the very high support and the routinely neuromuscular blockage was used, they had a better outcome. But the ROSE trial was done 10 years later, and in those 10 years we had very good sedation available. So now we sedate our patients very well without having asynchrony and dysynchrony. So they said do not routinely practice neuromuscular blockage. They don't say don't practice it, but routinely don't practice it. Try to achieve the sedation and synchrony with the adequate sedation. If at all with the adequate sedation also, when it is not working, then you can continue using the infusion of the neuromuscular blockage, but do not use routinely for each and every patient. Moment you have made that patient prone, it's not required to use the infusion. Moment the patient is ARDS or ventilated, it's not required to put your patient on the infusion. Initially you try a good titration with the sedation is not working, you can very well use a neuromuscular blockage agent. Now with all this, PF ratios again gone down to 60. Then consideration is ECMO. So if your center is ECMO center, you can wait till this. But if center is not an ECMO center, moment you prone the patient, when the PF ratio is less than 60, well less than 150 on 60% of FiO2 and PEEP of 5, that is the time you have to involve the ECMO center. You have to keep them in loop, tell them, see this is the patient, I have proned it, I don't know how the patient is going to behave. If it behaves well, continue proning. If doesn't behave well, then tell them to come and take the patient, cannulate the patient, rescue the patient, and they will rescue with the ECMO and take away to their centers. So when do we define about the ECMO? Of course, when there is a refractory hypoxemia less than 80 to 60. So this is the Murray score. What we follow when the Murray score is more than 3 or 2.5 is what we consider when the patient has to be referred to the ECMO center. But more on PF2 ratio less than 80, despite of all management, you check the driving pressures, you check the plateau pressures, hypercapnia. But despite of all, if the PF ratio is less than 80, even if you don't do the Murray lung injury score, you can refer that patient for the ECMO itself. So extracorporeal ECMO therapy has come from the Illulia trial, where they studied around 250 patients, and the primary outcome was the 60-day mortality, and the absolute reduction in the mortality was around 11%. In fact, just 15 days back, one paper got published in ICM, where they very clearly said ECMO has moved from the salvageable therapy to standard of care. Now we are not talking about whether to do ECMO or not ECMO. If you are doing ARDS, ECMO needs to be there. Only thing is timing of ECMO, when do we do it? That is what is required, otherwise become a standardized care. It's no more a salvageable therapy or rescue therapy. So either you can consider ECMO when the PF ratio less than 80 despite of everything for more than 6 hours, or less than 50 for more than 3 hours. If the pH is less than 7.25 and the PCO2 is more than 60, or the Murray score is more than 30. But usually they don't do well when your patient is already mechanically ventilated for more than 7 days, patient is on major immunosuppression, case of CNS bleeding, irreversible terminal condition, advanced age with poor functional status, those patients will not do well. So this is why the recommendation is come from the Illulia trial, where patient should go for the proning when the Murray score is more than 3. So this patient was done after 10 days of ECMO plus lung protective ventilation. It was successfully decannulated from the ECMO and weaned off from ventilator after 18 days. So what do we learned over here is HFNC NIV, low tidal volume, optimization of PEEP, prone ventilation, and consider ECMO wherever is required. And this is what we need to follow. ARDS.net trial, it's always available in all the studies. So you classify, follow any PEEP criteria. In moderate to severe ARDS, go with the higher one, it has a better control your driving pressure. Look for the optimum PEEP if you have the gadgets with you, and look for the acidosis management, especially the permissive hypercapnia. There's a chart available, you can follow it. So the learning points, ARDS is a stepwise thing. First define this is ARDS, look for the PF ratio, mild HFNC NIV, moderate low tidal ventilation with PEEP titration and equipment maneuvers, severe prone early, refractory go for the ECMO referral. Thank you very much. Thanks.
Thank you,
Absolutely
Dr. Bharat.
marvelous presentation. I think all the students must have learned the ARDS management very well. I think the things and concepts are very much clear, and they are going to do well in the exams too.
So, Dr. Bharat, since it was very elaborate talk, can you, for students' sake, can you tell us in say 5-6 lines what are the most important aspects that they need to follow and they need to monitor?
So it was the last key take message only what we spoke about. So initially when the patient comes to you, first is define it's an ARDS. You need to be very sure this is ARDS. Once it's ARDS, classify whether it's mild, moderate or severe. As per the classification, if it's mild, go for the non-invasive ventilation, could be the NIV or the HFNC. Both are good. But whenever you go on the NIV and HFNC, know your target failures. You monitor the failure very well, because if you prolong NIV and HFNC, the mortality really goes very high. So moment your NIV and HFNC, you need to monitor your whichever index you follow. You follow HECOSCO, you follow ROX index, or you follow Apache, or you do ABGs again and again, look for the PF whether it's improving or worsening. But that is very important once you're going with the non-invasive ventilation. If patient is improving, well and good. If not, you go for the invasive ventilation. Once you're gone for the invasive ventilation, as I told you, mode is not a problem over here. But for the benefit of the understanding and as per the recommendation, volume control is easy to practice because all recommendations are based on the volume control mode. So it's easy for you to go on. So as I showed you the chart, start with 8 ml, come down to 6 ml, then see where the plateau pressure is, either go up or further come down, looking into the permissive hypercapnia. Look for the appropriate PEEP. The simplest way is to follow the chart. In moderate to severe category of ARDS, higher PEEP. In the milder ARDS, mild to moderate one, the lower PEEP chart will also do. Recruitment, you don't do it as of now. Don't think much about it because that is still in the research phase. So you don't do into the RI things. Those are very high-end things. Just forget about that. If your patient is PF ratio is less than 150, even though the FIO to 60, prone that patient immediately. Now, once you prone the patient, start thinking about the ECMO, talk to the relatives about the ECMO. If with proning, mostly 90% of the patient will improve with the proning, if you've done it early enough. First 3 days of the disease, they will improve with the proning. If they are improving, it's well and good. If not, then call the ECMO team, let them come and rescue the patient. Thank you.
Thank you, sir, for such a wonderful session. I would like to request Dr. Sandeep Agarwal, sir, to felicitate Dr. Bharat Jagyasi, sir. I would like to request Dr. Sandeep, sir, to felicitate our chairperson, Dr. Nikhil Varghese, sir. Dr. Anita Jain. So moving on to the next session, I would like to request chairpersons on the stage, Dr. Prashant Zedge. Dr. Prashant Zedge as a chairperson, critical care consultant and intensivist, and Dr. Bharat Jagyasi, sir, Director Critical Care at Kokila Ben Dhirubhai Ambani Hospital, Navi Mumbai. So very often we select the common modes, that is volume control, pressure control and pressure support. and our patient doesn't seem to do good, and we often wonder what to do next. So for the next session, I would like to invite Dr. Manmohan Borse, consultant intensivist at Jaslok Hospital, Mumbai, who will guide us and explore us in the advanced modes of mechanical ventilation. Welcome, sir.
Hello. Yeah. Good afternoon, all. Thank you so much for the opportunity. Good afternoon, Bharat sir. Good afternoon, Prashant sir. Thank you for the opportunity once more. Okay, so building up, as I said, Dr. Prashant has already built up how ventilator can affect the synchrony and all, and how ARDS should be managed with the conventional modes and all that. So build up has already done, and most commonly we come across the pressure control mode or volume control mode, and nowadays the new mode, which is the pressure regulated volume control. It's one of the favorite for all of us. So that's what. So I'll start how conventional modes have their limitations and how we can work more on the advanced mode so that we can use it more often and we can well versed with it. Okay, so going ahead, so everybody knows the aim of the ventilator. The ventilation provides gas flow to the lung that is appropriate to maintain the adequate alveolar ventilation and oxygenation, at the same time causing minimal lung damage and having maximum comfort for the patients. So everybody knows the conventional modes like pressure control and the volume control. Here we set the targets on the ventilator, so patient has to adapt to the settings which we already set on the ventilator. Okay, so machine does what we have already set and patient has to adapt. Okay, so the character of the breath is same all the time. So as Prashant sir said at the end of his talk, one size does not fit all. So on next to that, in the same patient, one size does not fit same at all the time. Okay, so in the same patients, as patient improves or as he deteriorates, the same settings may not be appropriate. Okay, so the demand varies, so we need to adjust as per the demand of the patient. So one size does not fit all, and in the same patients one setting does not fit all the time. Okay, so if the patient is stable or patient's condition is same, the conventional mode works well, and most of the time we are able to do it successfully. Okay, but if the demand varies, we are struggling with it. Most commonly we struggle with the synchrony. Okay, so going ahead, so what are the limitations? As I said, if there is a demand variation in the demand, there will be inappropriate flow, there will be inappropriate volume or high pressures. Okay, asynchrony, which we already explained by the Prashant sir. There will be increased work of breathing automatically, because the power topic explained by the Bharat sir, definitely it will lead to the ventilator induced lung injury. Automatically all these things will affect the oxygenation. Okay, so what is the ultimate solution from our end? We'll sedate our SOS, will paralyze them. Eventually we prolong the ventilation, we call all of this lead to muscle weakness and eventually delayed weaning. So to cover all these things, we expect few things from the advanced mode. So coming to the expectations for the advanced mode, we want to combine the benefit of both volume control and the pressure control to have a better trigger, better synchrony, eventually leads to better oxygenation, and at the same time less lung injury, less sedation and faster weaning. Okay, so how do we classify mechanical modes of ventilation? So conventional, one side we have conventional modes, which includes the pressure control, volume control and the pressure support. On the other side, my topic mostly based on the dual control mode, like which I'm going to talk about the closed loop ventilation. So what does exactly closed loop ventilation does? So if you talk about conventional modes, what we have already said, the ventilator is delivering and the patient has to adjust to those settings. If he's not adjusting, it will lead to asynchrony. But in closed loop ventilation, the ventilation adjusts, it assesses the lung mechanics. Lung mechanics means it assesses the patient's compliance and resistance, and it adjusts few settings on its own by complex algorithm which has already inbuilt in the ventilators, and adjust the pressure or volume or the flow or the inspiratory time as per the patient's demand. That's why it is called as a closed loop ventilation, also called as a dual loop, because here we get the benefit of both the modes, volume control as well as the pressure control. In that also we have two types. One is the intra-breath variation and other one is a inter-breath variation. Intra-breath variation, in the same breath, ventilator can give a pressure control or pressure support mode, and it can eventually switch to volume control also, that is intra-breath. So that is about VAPs. So I'll come at the end of the intra-breath variation. Inter-breath variation, the breath pattern or the character of breath varies every cycle. Okay, depends on the demand or lung mechanics or the effort of the patient. That is inter-breath variation. So most commonly used mode in inter-breath variation is PRVC, pressure regulated volume control, assist support ventilation, ASV. Okay, and the other side, biphasic pressure mode, the most commonly most favored mode nowadays coming into the picture is a APRV. APRV is nothing but a airway pressure release ventilation. Okay, going ahead, so all these are not only the advanced mode, we call them as a adaptive mode also, because they adapt to the patient's demand. So there are simple, optimal, and there are intelligent adaptive modes. So in the simple adaptive modes is the PRVC, which comes into the simple category. The machine automatically adjusts the parameter based on the lung mechanics, and it varies breath through breath. Okay, the next category, optimal, which includes the assist support ventilation. So here machine uses complex algorithm automatically, and not only the pressure, it adjusts the respiratory rate, tidal volume, as well as the IE ratio. The next, which is yet to be there at the maximum level, but it is there, people are knowing it theoretically, is the intelligent mode. Here not only the tidal volume or the respiratory rate, the ventilator assesses the SpO2 as well as the EtCO2 to adjust the PEEP FiO2 along with the respiratory and tidal volume. And there are servo modes, where the servo modes includes the PAV and NAVA, proportionate assist ventilation, and NAVA. Machine matches the patient's effort. So more the effort, more the support from the ventilator. Okay, so let's start with the PRVC. So far so good? Yes? Till now understood the classification? Okay, so let's start with pressure regulated volume control. Okay, so it has combined features of volume control. It is actually primarily pressure control mode, but it guarantees the volume, the set target volume. First, it was introduced in a Servo 300, and now available in most of the modern ventilators with a different name, auto flow, volume guarantee, or adaptive support ventilation. So what PRVC does, it achieves the set target volume by a pressure control strategy at the lowest possible inspiratory pressure. Okay, we set a specific tidal volume which is assured by this mode, and at the same time we have the pressure induced lung damage is minimal in this mode. So when as Bharat sir said, when we talk about ARDS patients, when we set some 6 ml or 8 ml of tidal volume, to achieve that tidal volume, definitely when the lung compliance drops, the pressure shoots up. So if we have not capped the pressure limit in the alarm setting, the pressure can shoot up, and eventually it will actually, so in the purpose of achieving the set targeted tidal volume, we are actually affecting the patient when we are letting the pressure shoot up. So this is one solution to that not letting the pressure rise and achieving the set tidal volume. PRVC is one of the better option instead of the volume control. Okay, so how does PRVC achieves the set tidal volume at the same time not letting the pressure shoot up? It alters the peak flow as well as the inspiratory time. Okay, in a simple word, it alters the pressure to achieve the set targeted tidal volume. Okay, so how it works, it gives first test breath and see whether we have able to achieve the set targeted tidal volume. If we are able to achieve the targeted tidal or the set target tidal volume, then it continues at the same pressure. If the volume was not achieved in the first few test breaths, okay, it does not happen in one breath, it takes 2 to 3 breaths, but the modern ventilators, they are able to do it in one test breath itself. So okay, so if the volume has been achieved, the pressure will be the same in the next cycle also. Okay, but if the volume is under the set target, then the pressure has to go up to match the set target of the tidal volume. And the other way around, if the if the tidal volume has been shooting up, or the tidal volume has more in the test breath, the pressure will automatically drop. Okay, so based on the compliance of the patient, the ventilator adjusts its setting. It reduces or increases the pressure to match the set tidal volume. Understood? Okay, so what we need to set here, we need to set the, apart from the FiO2 and PEEP, which is the first thing to set if you are dealing with ARDS, okay, we need to set the tidal volume 6 to 8 ml per kg of predicted body weight, and we need to set the upper pressure limit, which we keep it around 35 to 40, and the pressure in PRVC will go up to 5 centimeter less than the set limit. If you set 40 in PRVC, the pressure will not go more than 35. Okay, it will try to achieve that. It will, with that pressure, it will try to achieve the set targeted tidal volume. Okay, we set the age appropriate respiratory rate and I ratio to begin with as 1:2. So what are the advantage of PRVC? It guarantees tidal volume with a minimum risk of barotrauma, as it does not let overshoot the peak pressures. The decelerating flow. Okay, so volume control, there is a square waveform, but in a pressure control, why? So as sir said, volume control prefer strategy, but there are a lot of discussion about the pressure control over the volume control in ARDS patient because of the decelerating flow pattern in the pressure control. So PRVC gives you the decelerating flow along with the volume control benefit. So we have, and decelerating flow is more physiological. It has a better distribution of ventilation, so it is preferred over a square waveform pattern. Okay, automatically better synchrony and lesser peak pressures. Okay, eventually as the compliance improves, the same tidal volume which we were getting at a pressure of 30, now the at the 30 pressure, the volume is shooting up. The targeted volume, if it was 450, now compliance is improved, the tidal volume is going at 500. So the ventilator will sense it and it will reduce the pressure from 30 to 25 over 20. So automatically it starts gradual weaning on its own, or it reduces the pressure. So that big advantage in PRVC. Limitation, the tidal volume is not constant as we see in the volume control ventilation, and if patient makes significant effort, the pressure, the ventilator can set it abnormally, and sometimes it can give extra support, which eventually it will be harmful for the patient. So that are the limitations. Okay, going ahead, the next optimal support adaptive mode is adaptive support ventilation. It has evolved from the mandatory mechanical ventilation. Okay, it automatically adjusts the respiratory rate, tidal volume, and so what exactly ASV does, it selects appropriate tidal volume and respiratory rate for the mandatory breaths. Okay, so it switches between the pressure control and the pressure support. Interbreath variation, again, this is not intra-breath, this is a interbreath. Intra-breath, it switches between the pressure support and pressure control or volume control in the same breath. This is interbreath variation. It switches between the pressure control and pressure support, interbreath, but shows the tidal volume again. Okay, so if the patient has a good effort, it goes into the pressure support mode. If the patient is having not great effort, we need to give mandatory breath. The ventilator chooses the appropriate tidal volume and respiratory rate. Okay, so here what we set a minute ventilation based on the patient's gender and height. Okay, so it, as I said, it does not adapt only the pressure, it adapts the tidal volume, respiratory rate, and I ratio. Okay, the breath character completely decided by the ventilator. In the conventional mode, the breath character is decided by us. We set few targets and then the ventilator delivers. Here, based on the patient's mechanics, the ventilator decides the breath character. Okay, so again, like a PRVC, it delivers the first few breaths, calculates the expiratory time constant, and which utilizes in the OTS equations. So I'm not going into that detail. Okay, but eventually it calculates the required tidal volume, required respiratory rate to achieve the set minute ventilation. Okay, so what settings we set in ASV? We, apart from the FiO2 and PEEP, we set the input gender and height to calculate the ideal body weight, and then we choose percentage of minute ventilation to be supported by the ventilator. Okay, so if it is active disease, sometime we give 100% of minute ventilation required as per his ideal body weight, or if it is weaning phase, patient is getting better, we can reduce the minute ventilation support to the ASV. Okay, the advantage again same. Okay, it assures the volume like a PRVC, assures the volume, which is the benefit of volume control ventilation. The benefit of pressure control also comes here, the decelerating flow pattern, because it switches between pressure control and pressure support. It is again the pressure control based strategy, but has a volume benefit, a guaranteed volume benefit. Okay, it automatically adapts as per the patient's efforts, and it eventually decreases the work of breathing. Okay, again the weaning is faster or better in ASV. Okay, yeah, the limitations, less control for us, because the ventilator is, we are just giving the height and gender and deciding the percentage of minute ventilation is required. The ventilator decides the respiratory rate and tidal volume. Okay, less control for us and not very ideal for the ARDS patients, as we target the lung protective ventilation. Okay, so difference between PRVC and ASV. Okay, in PRVC we set a target tidal volume and ventilator adjusts its pressure. In ASV we set a percentage of targeted minute ventilation, ventilator adjusts its respiratory rate and tidal volume combo, and it switches between the pressure control and pressure support interbreath, between breath to breath. So one breath is delivered pressure control, if the patient's effort is good, patient can go into the pressure support mode, interbreath variation. Okay, so if you see compare the curves of both PRVC and ASV, in a PRVC the volume curve is same in all the breaths, because we have set the tidal volume. Okay, and the pressure is getting varied as per the patient's compliance. But if you see the lower curve, which is the assist support ventilation ASV, here as per the patient's demand, okay, as per the patient's compliance and as per the need of the minute ventilation, the volume curve can vary. Okay, so just to test your knowledge, I'm going to put 2 MCQs so that we can have a better understanding of PRVC and ASV. So this 165-year-old male ARDS on PRVC, initially the compliance was good at 40 and then the set tidal volume was at 420. After 2 hours the compliance worsens, drops to 20 from 40. Which of the following best describes what will happen in PRVC mode? Answer? So will it be tidal volume will decrease because the compliance has decreased, or the inspiratory pressure will increase to maintain the same tidal volume as we have set in the initial settings, or both tidal volume and pressure will constant, or the ventilator will automatically reduce the tidal volume as because the compliance has reduced? What is the best answer? A, D. Okay, A, D, yeah, good. Anything else? B, C? Anybody B? Please raise your hand. This should be interactive session. Otherwise, advanced mode are pretty much in theory and we just will study here and then we'll forget. So okay. So just to have something in our mind, to get it back. Okay. If we have better to have interactive session. So answer please. Okay. Somebody said A. Somebody said D. Anybody for B? Only 2 people. Okay, so as I said in the PRVC, there are 2-3 people who said B, because here the pressure gets adjusted as per the compliance to achieve the set target volume. So the correct answer is B. Okay, what PRVC does, it adjusts the inspiratory pressure based on the compliance to deliver the same set target volume. That's the benefit of PRVC. That's why this MCQ was involved here. Okay, coming to the next MCQ, a 50-year-old patient recovering from pneumonia is placed on assist support ventilation with a percentage of minute ventilation set at 100%. Patient is in active disease, we are giving 100% support for the minute ventilation. The patient becomes more awake and he starts generating strong spontaneous breaths. How will the ventilator typically respond? Here patient is responding with a strong spontaneous breath. So what will happen? How the ventilator will respond in ASV mode? Will it continue delivering the full breath as a control breath, as we have set in the previous settings, okay, or the initial settings, or it will log the original respiratory rate and tidal volume regardless of the patient effort, or it will intermittently gradually shift from PRVC like pressure control to the pressure support breaths, lowering the assistance as because the patient has started putting up its own spontaneous efforts, or it will switch automatically between volume control to square wave flow. Yeah, good. So thank you. So I think I made it clear to PRVC and AVC. So the correct answer is C. Here it switches between pressure control and pressure support based on patient's effort. Going ahead with the complex mode, APRV, it is nothing but a biphasic mode, airway pressure release ventilation. Okay. Now many people are favoring this mode in advanced ARDS patients or severe ARDS patients. Some of them do try it before actually considering the ECMO also. We recently had a patient with a severe ARDS where the PF ratios persistently around 70-80 even after proning. We did try this for one day, but it did not help. Eventually we had to go for the ECMO. Okay, so it is one of the people are preferring to use this mode now more commonly in severe ARDS patients and one of the rescue strategy. Okay, so what exactly APRV? It is a time trigger and time cycle, but pressure control. So time trigger, pressure control and time cycle mode. Okay, so what exactly APRV does? It facilitates spontaneous breathing. That's the biggest advantage. The third line, please read carefully. This is the biggest advantage of APRV. It facilitates spontaneous breathing of the patient at both the pressure level, at high pressure as well as the low pressure level, because it's an open circuit. It works like a CPAP, okay, in a NIV BiPAP, where it's an open circuit. Patient can facilitate its spontaneous efforts whether the ventilator is in inspiratory phase or expiratory phase. Irrespective of that, patient can take its spontaneous breath. So it can be vice versa. That's the biggest advantage of APRV. APRV maintains lung at high pressure. That is nothing but a P high at a longer period of time. That is a T high, and which eventually decides recruitment of the lung and oxygenation. So P high and T high decides oxygenation, and the other setting it releases the intermittently, which decides the low pressure, that is a P low, and whatever the amount of time that P low is staying there in the setting, that is a T low. So P low and T low decides the ventilation, that is a removal of the CO2. So P high and T high decides the oxygenation, and P low and T low decides CO2 removal. So these are the four settings in APRV: P high, P low, T high, T low. So PI is nothing but the baseline airway pressure, which is mostly equivalent to the plateau pressure. So before going to APRV, we calculate the plateau pressure on patient. We take the patient on volume control, put an inspiratory pause, and then calculate the plateau pressure. And based on that plateau pressure, we calculate the P high. So if the plateau pressure is somewhere around 30, 35, so we don't go above 30. We keep the P high between 20 to 30. Okay. The P low, some people describe it as a PEEP also. It is nothing but a PEEP, but it is a P low which decide the CO2 removal. Usually we keep it 0. Some people prefer to keep it at 5 also. Okay, you people say that keeping PEEP 0 in APRE won't we allow the patient de-recruitment. You are right, but keeping the pressure high at longer period of time, the P high keeping at longer period of time, which actually recruit the lung, and the P low will de-recruit the lung, but the time which we keep the P low is very minimal, and that's why the T low is the most difficult to set among all the four. Okay, it should be short enough so that patient should not de-recruit, because if you set the if you set the P low at longer period of time, the patient will de-recruit. Okay, so it should be short enough so that patient should not de-recruit and oxygenation should not hamper, but at the same time it should be long enough so that there is adequate alveolar ventilation and there is enough time to wash out CO2. So far so good. Little complex, but these are the four settings. Okay, P high, P low, T high, T low. Okay, T low is the most complex among all four. Okay, so you can see the waveform down. So the P high and T high is nothing but an inspiratory phase of the ventilator, and the P low, the time is nothing but an expiratory phase. And if you see the down at the left corner, the spontaneous breaths are happening at all the time, irrespective of the ventilator, whether it is in inspiratory phase or expiratory phase. So whatever the time when the P high is there, that time is nothing but an inspiratory phase. What is the time, the T low, that is nothing but an expiratory phase of the ventilator. Okay. So what key adjustment we do in APRV? If the patient has hypoxia, if the FiO2 is high, we need, so definitely if we need to increase the FiO2 if the patient has low PO2. That is the first adjustment we do commonly. But if the patient has already on 100% FiO2, what other settings you will adjust in APRV? You will increase the P high. Okay, the actual math is P high minus P low. It's we are actually increasing the gradient. Okay, but you can do that by increasing the P high, and that will help to improve the oxygenation. Other way around, you can increase the T high. Okay, the inspiratory phase, the pressure, the high pressure, you can keep it for longer period of time. That will help also for the oxygenation. Okay, and how will you adjust your ventilator settings in APRV in hypercapnia? Here the T low and P low decides the oxygenation, the CO2 removal. So, but as Bharat sir said, we in ARDS patients we allow permissive hypercapnia. If the patient's pH is above 7.15 or 7.2, we can accept that CO2. But if still the PCO2 is shooting up or the pH is dropping less than 7.15, what we need to do? We need to reduce the time of the release ventilation. We need to reduce the time of expiration. We need to reduce. Okay, we need to increase the time. So we can. I'm sorry. Okay, so if we need to adjust the T high, we need to increase the time of expiration. So by reducing the T high, you are actually allowing the T low to be there for a longer period of time. Okay, got the point? I just confuse you guys rather than reducing the T low. Here what we need to do, we need to increase the T high. So how will you increase the T high? You can reduce the here we need to increase the T low. So how will you do that? We will reduce the T high. So far so good? Some confusion is there? Sorry. Okay, so in hypercapnia we need to reduce the T high. Okay, so advantage of APRV, it improves the oxygenation, maintains annular recruitment and high mean airway pressure, allows the spontaneous breathing, reduces the need for sedation, it reduces the ventilator induced lung injury and allows the inverse ratio. This is nothing but an inverse ratio ventilation. Okay, you are keeping the inspiratory phase for too longer period of time. The ratio here is almost, see, ideally we set IE ratio in volume control is 1:2. Here we are setting ratio of almost 4:1. This is inverse ratio ventilation. Okay, so that's the advantage of APRV. Limitations, hypercapnia is the biggest struggle here because the T low is there for the P low and T low is very short, and we want to avoid the D recruitment in ARDS. So we usually struggle with managing the carbon dioxide removal here. Okay, the risk of volutrauma, barotrauma may be high if your PI is set too high. So we cap the P high at maximum 30 even if your plateau pressures are high. Okay, so it requires clinician's experience and we need to monitor regularly. Okay, so the MCQ on this, a 36-year-old trauma patient on lands up in ARDS, we kept him on APRV. We set the initial setting P high 30, T high 6, P low 0 and T low 0.6 seconds. So the flow time curve shows exhalation continues almost to 0. Okay, at the end of T low. So after 2 hours, the patient lands up in hypoxemia. Okay, and because of the worsening compliance. Which ventilator adjustment will be done? What ventilator adjustment will be done? Among 4, which will be your setting? I need everybody to answer this. Anybody? Decrease T low? Yes. A? Increase P low? Increase T low or decrease P high? Okay, so you are right. The correct answer is increase T low. Okay, here we are struggling with a hypoxemia, so we need to avoid de-recruitment. Okay, so as I said, T low is the most difficult to set. We need adequate time for alveolar ventilation, but at the same time it should not be prolonged so that patient gets de-recruited. You are recruiting the patient with a P high. We are keeping the high pressure at some longer period of time, and if you prolong the P low more than the appropriate time, it will de-recruit the patient, and that will eventually lead to atelectotrauma also, and it will cause the hypoxemia. So the best adjustment in this scenario, decrease the T low. If you increase Okay, so other options, if you think about option B and option C, okay, increasing the P low and decreasing T low, it will actually worsen the oxygenation because you are letting the lung derecruit, and decreasing P high will further worsen the oxygenation because if A was not answered, then the answer D should have been increase the P high to improve the oxygenation. Understood? Okay, so coming to the servo modes, I think we 3 modes we have covered till now: PRVC, ASV and APRV. Next mode, servo, is a proportional assist ventilation. Okay, it's nothing but it matches the patient's effort. If the patient is putting more effort, the ventilator will give the more support. Okay, more the effort, more the support, and it is nothing but a proportional amplifier. And we set how much pressure to be given by the ventilator. If we set the support between 20 to 80, like we set the pressure support between 20 to 80%. Let's see, you set the pressure at 50. So if the patient is making effort 50%, the ventilator will deliver the rest of the 50% of the support. Okay, so where it comes handy in case of patient who has a good respiratory drive, patient is getting better from your ARDS or whichever the primary pathology, and now you want to wean off this patient, you try them on PSV. They do have a good respiratory drive, but the problem with pressure support, you have set the pressure. Okay, and based on a patient's effort, if the patient effort is good, the same pressure will deliver a good tidal volume. But if the patient effort is poor, the pressure is already set. So what will happen? The delivered support from the ventilator will be quite less. So automatically it will lead to us in what we feel the SBT trial is unsuccessful. But the patient had a good drive. So what we had to do exactly, we had to increase the support, breath to breath. Pressure support does not give us that advantage. What it does, it keeps the same pressure, constant pressure, regardless of the patient's effort. Okay, but PAV does opposite to that. What PAV does, it increases support if the patient's effort is less. If the patient putting only 50% effort, it will give 50% support. If the patient is putting more effort, or if the patient's effort is patient is putting more effort, then the support is requiring high. That means it adjusts the support as per the patient's demand. Okay, you can see here the upper curve is of pressure support, the lower curve is of pressure associated ventilation. Okay, so if you see the first image in a PS, the effort is low. Okay, but the PS is same. As effort goes up, even the pressure support is the same. But if you see in the PAV, the pressure, if the patient effort is more in the second image, the pressure has increased. Eventually increase in pressure will lead to increased delivery of the tidal volume. That's the next image. Okay, so here you can see in the PAV, if the patient effort is more, the inspiratory pressure goes up and it delivers higher tidal volume. So it matches the patient support. So more the effort, more the support. That's the advantage of PAV over the PSV. So it is one of the favorite mode for many people for weaning. Okay, so advantages and limitations of PAV, it matches the patient's breath. So eventually definitely improves synchrony. We can have a successful SBT trial. It shortens the weaning. Okay, allows variable tidal volume and flow, mimics natural breathing of the patient. Okay, and encourage patients to breathe because we are assisting as per his demand. If he is putting more effort, we can support high. If he is very much comfortable, the patient unnecessarily won't give high support to just push the set tidal volume. It will adjust accordingly. Okay, the limitation, it's a dry limited. Okay, so if the patient has no respiratory dry, if he is not triggering appropriately, then the control modes are better. So it's preferably used for the weaning modes. Okay, sometimes risk of over assist is there. Okay, and not universally available in on ventilators. Coming to the next, NAVA, neurally adjusted ventilatory assist. Okay, this is the next level of the proportional PAV. Okay, what the current ventilator do? Okay, so the respiratory centers give command through the phrenic nerve to the diaphragm, which leads to diaphragm excitation, and which leads to diaphragm contraction, and which leads to eventually chest wall expansion and lung expansion, and which eventually alters the patient's flow and pressure. So currently we are at the bottom. Okay, the PRVC and APRV, which PRVC and AS, which I talk about, though they are adaptive, but they adapt to the patient's pressure, flow, once the patient's lung expansion has already been done. So it's quite late. The adaptation is little late, so that takes time. So what we want to adapt little higher, much before patient actually goes in the lung expansion. Okay, so the current strategy is that when the patient alters its flow or pressure, the ventilator sense it and gives appropriate breath. But what NAVA does, it adjusts to the neuronal setting, neuronal signals from the diaphragmic excitation. Okay, that's where we are targeting nowadays. Okay, so what exactly it does, it amplifies the diaphragm's neuronal activity. So what we measure here, we measure EDI, electrical activity of diaphragm, okay, which is captured through a specific electrode for the NAVA mode. So we need to put a electrode through the esophagus. Okay, you can see the electrode going down in the esophagus below the diaphragm. Okay, all those electrodes mention the EDI, diaphragmic electrical activity or diaphragmic excitation, and gives to the ventilator processes it, and based on the patient effort the ventilator adjusts its support. Okay, that's a neurally adjusted ventilatory assist. Okay, so what exactly how it helps, it synchronizes, it decides when to initiate the breath, when to terminate, and the magnitude of the supports. All this can be done in a better and synchronized way. Okay, so what one setting we have to do, we have to adjust the NAVA level, we have to set the NAVA level. Okay, we have to monitor the EDI and tidal volume. Based on the EDI, we need to monitor the tidal volume. Okay, the NAVA decides the EDI, and we set the EDI based on the NAVA and monitor the tidal volume. If the EDI is reducing and we are achieving the same tidal volume, that means the patient is getting better, so the the pressure support will reduce automatically. Okay, so the patient is ready to wean. Okay, too much of theory here, but you can take home from this mode that it is advanced mode where we are targeting the diaphragmic excitation, and the ventilator is using complex algorithm and adjusting its pressure based on the diaphragm excitation much before drop in pressure or flow in circuit. Okay, so we can speed up weaning by adjusting the NAVA levels. Okay, once the EDI is less than 10, we can extubate the patient. Advantages of NAVA: excellent synchrony, because we are adjusting the ventilator settings much before patients go into the drop in pressure or peak flow. Okay, so it has excellent synchrony. Triggering, cycling, pressure delivery all matches to the patient diaphragmic activity of the patient's effort. Okay, prevent over and under assist, may help diaphragmatic activity. Prolonged ventilation, we struggle with the weaning because of the diaphragm weakness. Okay, here it pushes diaphragm to functional better way. Okay, limitations: we need a specific nasogastric catheter, the cost, the availability of that catheter, the placement should be appropriate, any movement of the patient, the catheter can get displaced and the sensing will be inappropriate. Okay, and not suitable for the patients who are having weak or absent respiratory drive. Coming to the intra-breath variation, the VAPS, volume assured pressure support. As I told you in the beginning, intra-breath is a PRVC and ASV. It is intra-breath. This in VAPS, this is primarily pressure support. Okay, but as the patient's effort is not adequate, the ventilator switches in the same breath cycle, switches to the volume control. That's the advantage of the VAPS. So here we have the guaranteed tidal volume, but the patient switches between the ventilator switches between the pressure support and volume control. Okay, so if the patient's effort is good, adequate, the pressure support breath will be delivered and the target volume will be achieved. But if the patient's effort is inadequate, then in the same breath cycle, ventilator switches to the volume control and it will deliver the set tidal volume. Okay, the advantage of VAPS is patient will receive minimum pressure support and peak flow, and it will achieve the set minimal targeted tidal volume. Okay, so this exactly what it does. If in the first half, if you see them on my side, the patient support, the patient effort was good, so ventilator has given the pressure support breath nicely. But in the next cycle, the patient's efforts were not adequate. In the same cycle, it started as a pressure support, but we were not able, the patient's effort were not great to achieve the set tidal volume or minimum tidal volume. It converted into the volume control. That is nothing but a VAPS. That's what VAP does. Okay, coming to the next mode, HFOE. Okay, so it's out of favor, very complex. I have used it only once in Apollo Chennai in a severe ARDS patients. We were failing with everything else. So nowadays, like it's been 8 years I used it. So I'm not sure how many people are using it, but you should be knowing it theoretically. Okay, it delivers very small tidal volume at very high frequencies. Okay, so when we talk about volume control ventilation in ARDS, we talk about lung protective ventilation, 6 to 8 ml per kg of volume, but HFAV gives very small tidy volumes. Okay, but the frequencies are high. So by doing that, so what is the formula of minute ventilation? Tidal volume into respiratory rate. So eventually our goal is not only the tidal volume, we need to achieve the minute ventilation. So how HFAV does? It gives tidal volume, but it still achieves the minute ventilation. How? It increases the rate. It increases the, we give those low tidal volume at much higher frequencies. So by keeping those high frequencies and the low tidal volumes, we achieve very good pressure. We achieve very good mean airway pressure. That mean airway pressure helps to maintain the oxygenation. So how oxygenation decides in HFAV? By high mean airway pressure. The ventilation is decided by the oscillating piston, by this high frequencies. Okay, so little complex, but you can see there is low tidal volume at much higher rate. The patient is breathing almost at the rate of 180 to 200 cycles per minute. Okay, we set how many respiratory rate? 10, 20, we go up to 35, but in HFOV we set much higher respiratory rate. Okay, that is all about HFOV. Okay, coming to the last, interleavent, still to be favored, but what exactly it does, it not only adjusts the, it not only assesses the mechanics, it assesses the patient's SpO2 pattern as well, EtCO2 as well, and not only adjusts the respiratory or tidal volume or the flow, it adjusts the PEEP and FiO2 also. Okay, so again more of theoretical thing, but you should know the interleavent is the upcoming future, and now AI is coming everywhere. Maybe this will be the future. So in the previous advanced mode, we need to adjust the PEEP and FiO2 based on the oxygenation, and the other tidal volume, peak flow, pressures, I ratio can be managed by ventilator on its own as per the patient demand. But interleavent will do both. It will adjust the CO2 settings as well as the oxygenation setting by assessing the EtCO2 and PEEP. Okay, so how advanced mode has evaluated? It was open loop before, the conventional mode, which was nothing but a volume control and pressure control. Then we came across with a open circuit. Open circuit is nothing but a biphasic, the APRV, airway pressure release ventilation. And now people's favorite, closed loop. Closed loop includes, it titrates based on the patient's effort. If the based on the titration, we classify the modes. If the ventilator assess titrates based on the mechanic is nothing but compliance and resistance, that is nothing but a PRVC. Based on patient's effort as well as the mechanics, those are the PAV and NAVA. Based on the breathing power, ASV, and now coming down to the bottom, again, like next level, it is AVM2 or the adaptive ventilator mode. Okay, this is next to ASV, which I did not take in detail. Okay, but that is, we talk about inspiratory power rather than the breathing power, because as Bharat sir said, not only the pressures, it is the respiratory rate and how frequently you give those pressure, that is all power is eventually causing the lung trauma. So we need to talk about power, not only the pressures. Okay, so the summary: adequate safe ventilation with synchrony and good gas exchange is very important for early weaning and safe ventilation. Okay, conventional modes deliver the fixed pattern, the breath will be same all the cycles as we have said to begin with, not suitable for varying efforts. Okay, so we need to adjust the setting, as I said to begin with, that same setting may not be fit to all the patients, but in the same patient, same setting may not be suitable all the time. So we need to adjust, and we are too busy to adjust the setting every time. That's why the advanced mode comes handy. They adjust their setting as per the patient's demand. Okay, they are adaptive, they are proportional, and they are more synchronous. They reduce work of breathing and they are more comfortable. That means there is less need of sedation and we can wean off the patient rapidly. Okay, coming to the evidence, there are only 2-3 studies. One was done in China in 2017. They studied APRV in 138 patients. Okay, so they did show better results in terms of reduction in alarm time, reduction in nursing utility, or like they are not going and pressing alarms again and again or shutting down the alarms. Okay, so eventually talking about alarm, it actually helps the patient to have a less alarm because it eventually affects the delirium. Okay, so that study did show some benefit in terms of the reducing the alarm and nursing time. Okay, did show some amount of oxygenation betterment, but there was no mortality benefit. So we need to do further evaluation about the advanced mode, but people are using it more commonly. As we use it more commonly, maybe we can have more trials and people will well versed with it. Okay, thank you. So at last, a mode of ventilation is only as good as operator who applies it. So you can save your patient by the volume control also, but if you are well versed with the APRE, you can save him with APRE also. Thank you. Thank you.
Thank you, sir, for the wonderful session. I would like to request Dr. Sandeep Agarwal, sir, to felicitate Dr. Manmohan, sir.
For that, any questions? So these advanced modes are something you may not have seen, right? So it is always difficult to get a gist of advanced modes just on theory lectures. So we will be having a hands-on session on advanced modes, right? So we will demonstrate you how it is done and in which conditions and how you should do it, right? So keep your focus on that.
I would request Dr. Bharat, sir, to continue as a chairperson for the next session also. Taking a patient off the ventilator isn't always easy. So in the next session, we will learn how to make weaning safer and easier for our patients. For the next session, I would like to invite Dr. Archana Thakur, working as a head of critical care and emergency at MGM Hospital, Vashi. Welcome, ma'am.
Good afternoon, everyone. So after learning how to troubleshoot the ventilator, how to deal with the asynchronies, and how to deal with the ARDS patients, and how to use advanced modes, now I will come to the part where we are learning how to liberate our patients from mechanical ventilation. Okay, so first I will start with certain definitions. So whenever we are weaning our critically ill patients who are on mechanical ventilation, they each have to go through 3 steps. First step is you have to test whether they are ready to be weaned. Second is weaning strategy. Third is extubation, which is the final liberation from the mechanical ventilation. So readiness testing, we are using objective clinical criteria and certain physiological tests to determine whether our patient is ready for the weaning process. In weaning strategies, weaning is the process where we are gradually reducing the support of the mechanical ventilation and we are allowing our patient to breathe spontaneously. Okay, so we have to select which weaning strategy. I will be discussing it later in my presentation. And extubation is the final process where we are liberating our patient from the mechanical ventilation by removing the endotracheal tube. Okay, there are certain more definitions about the weaning. So simple wean, so patients are considered to have undergone a simple weaning if they have passed their first weaning trial. That means they have got extubated, they have got liberated from the mechanical ventilation after single spontaneous breathing trial. Difficult to wean patients are those patients where they have failed their first spontaneous breathing trial and they have required up to 3 SBTs or 7 days to pass an SBT. So these patients are categorized under difficult to wean patients. Prolonged weaning patients are those patients who have undergone prolonged weaning if they have failed at least 3 SBTs or they have required more than 7 days to pass an SBTs. So we'll be discussing how to deal with such patients in our later part of the presentation. So these are the topics I will be covering. So first, coming to readiness to wean. So why we have to test the readiness to wean? So we have to identify those patients who are ready to wean so that we are avoiding unnecessary excessive mechanical ventilation, okay, and therefore we are diminishing the risk of complications which are caused by mechanical ventilation like barotrauma, ventilator-induced lung injury, etc. And by doing so, we are identifying patients, those patients who are not ready to wean. So we are avoiding premature weaning. So thereby we are avoiding reintubations, failed weaning, etc. So what are the clinical criteria we use to identify the patients who are ready to be weaned? Improvement in the underlying cause of respiratory failure. This is the most important. So your patient has to be improved from the condition for which you have put the patient on the mechanical ventilator. So like suppose you have put the patient on mechanical ventilation for ARDS. So ARDS should have improved, the ventilatory support should have started reducing. Or suppose you have put your patient for COPD, type 2 respiratory failure, then there is improvement in the auto PEEP, improvement in the pH compensation, the CO2s have come to the baseline level. So those are the criteria. I mean, so that is why it is very, very important that the primary cause for which you have intubated or mechanically ventilated the patient, that has been sorted. Second is adequate oxygenation. Third is arterial pH should be reasonable, more than 7.25 at least. Hemodynamic stability, so patient should be reasonably hemodynamically stable. So the pressure requirement should be at an optimum level, not very, very high pressures. Patient should not be very, very hemodynamically unstable. And ability to take spontaneous respirations. These are the optional requirements. Just to mention, hemoglobin level more than 7, core temperature. So fever will impair your weaning process because of the fever, patient will have tachycardia, tachypnea, and that may impair your weaning. And awake or easily arousable mental status. Sometimes people do see diaphragmatic excursions by ultrasound. So here more robust data is needed, but yeah, it can aid to identify the patients who are ready to be weaned. So here what you see the diaphragmatic excursions in inspiration, in expirations, or you may see diaphragmatic thickness fraction. So here you take the thickness at the inspiration, then you take thickness at the expiration, and you take out the fraction. So thickness at inspiration minus expiration divided by expiration into 100. So like that you calculate the fraction. And suppose your diaphragmatic excursion is around 10 mm. There you have you may consider your patient ready to be weaned. And for DTF, the cutoff value is 21.5%. But these are not very sensitive and specific, so you just can't solely depend on that. So it can aid. Now coming to patients who have uncertain, patients who are with uncertainty. So here your weaning predictors can help you. So the most commonly used weaning predictor is RSBI. You must have heard about it, rapid shallow breathing index. So how do you calculate it? You calculate it by taking out the ratio of respiratory rate divided by tidal volume in liters. Okay, so how can you measure it? So you must be doing it, right, when you are weaning your patients. So you may do it by a handheld spirometer which is connected to the ET tube, which we hardly use, or simple way you can do it on the pressure support. So you can reduce the pressure support and PEEP of the ventilator, and you can actually count the RSBI. But here the data says that you should actually count the, suppose you are doing it on the pressure support, you should actually count the respiratory rate of the patient by looking at the chest movements, because sometimes the efforts are not being evident on the ventilator, and you may think that okay, RR is not very high, but actually the patient is tachypneic. So you have to take care of that. Other caveats are, suppose your patient is having a narrow endotracheal tube, female gender, septic patient, febrile patient, position, anxiety, and chronic restrictive lung disease patients. So here you have to judge clinically. You cannot exactly go by the numbers. So these are the caveats you have to take care of. So RSBI of more than 105 is a negative RSBI, and that indicates that patient is likely to fail. And a RSBI which is less than 105, that is positive, and which predicts that patient is likely to succeed the weaning. Please remember, a negative RSBI is having more importance because it is better at predicting the patients who will fail weaning rather than a positive RSBI who will predict that which patients will succeed the weaning. So negative has got the more value. So there are other predictors also which have got the theoretical value. I will just mention them. We will not go into the details. So like PF ratio of arterial oxygen tension to alveolar oxygen tension, alveolar arterial oxygen gradient, measurement of dead space. Then you can measure the load on the respiratory system and the respiratory capacity. So the work of breathing, minute ventilation, compliance, respiratory system compliance, diaphragmatic ultrasound I have already discussed with you, maximal inspiratory pressure, etc. There are multi-component integrative indices also, like you have this RSBI, then you have different indices which you can combine, and like crop index, core index, weaning index, integrative weaning index. So this was about the readiness to wean. So after we have seen whether our patient is ready to wean or not, we go into the weaning strategies. What weaning strategies we can adopt to see whether I can finally liberate my patient from the mechanical ventilation. So those patients who are intubated for less than 24 hours, you do not necessarily need a proper weaning trial for them. You know, like some straightforward elective post-op patients, and who have been ventilated for less than 24 hours, you can straight away go to the this thing. You don't need a proper weaning trial. For patients who have been intubated for more than 24 hours and have been deemed ready to wean, you should give a weaning trial. And the most preferred method is daily spontaneous breathing trials. Okay, so with inspiratory pressure support. That is the preferred method these days. There are older methods also where patient was put on pressure support and there was gradual reduction of the pressure support and finally the patient was weaned. Or patient was put on intermittent mandatory ventilation and you gradually reduce the rate and let the patient breathe on it and then you wean the patient. So these methods are no longer used. The preferred method is you put the patient on the pressure support mode, you give the spontaneous breathing trial for 30 minutes and then you take a call whether you can liberate your patient finally. So there are newer weaning methods also, like AI has come everywhere, so computer driven automated PSV weaning. So here again the data are limited, so you can go both the ways, manual or automated. But of course you have more data for the manual at the moment. Eventually we'll be going to the automated systems. So now coming to the protocolized versus non-protocolized weaning. So as we all know, so protocolized weaning is preferred. What has been shown in the studies that the duration of mechanical ventilation was reduced by 26% compared to the usual care group. So where the physician in charge is deciding, okay, now I will go for the weaning. So rather than a protocolized weaning which is set in your ICU, so everybody is tuned to it. Okay, now my patient is ready to wean, I will put the patient on the spontaneous breathing trial. So there is a protocolized weaning and a non-protocolized. So of course protocolized weaning is preferred. Thereby you are reducing the duration of mechanical ventilation. It is not based on only one person's perspective. It is like an overall protocolized approach. So everybody is attuned to the system of weaning and you know when your patient is ready and when you can start the weaning process. So by the guidelines also say that the pressure support which I had discussed earlier, so the pressure support which is consistent with the recommendations of American College of Chest Physicians and Thoracic Society. So this is usually used. So you put the patient on minimal pressure support with minimal PEEP to overcome the resistance of the circuit. You give them a breathing trial for 30 minutes to 2 hours and you decide on the extubation. So what is the advantage? So TPs was also used, right? So still many centers are using TPs. So what is the advantage of pressure support? So pressure support will reduce the work of breathing because your patient is breathing through the endotracheal tube. And of course there is a resistance, there is increased work of breathing. So by giving pressure support, you are overcoming that resistance, and it facilitates weaning in a smoother way. And also you can check the patient's mechanics very well on the monitor, and that can really aid you in deciding whether your patient is ready or not. So this was one big randomized control trial which was published in JAMA. So here they had compared pressure support versus TP's ventilation strategies during spontaneous breathing trials. So here again, overall the duration of ventilation was reduced. You had more successful extubations when you had used the pressure support ventilation rather than the plain TP's trials. And reintubations rate were higher in TP's group. And where in certain patients where you are expecting a high risk of extubation failure, then the data suggests that pressure support is definitely superior to TP's as a weaning strategy. So how will you detect weaning failure in your patient? So you have put the patient on spontaneous breathing trial, and how you will know that patient is having failure in the weaning. So these are the criteria. So you have to look for the tachypnea, drop in saturation, hypercapnia, tachycardia, hypertension or hypotension. There will be signs of increased work of breathing, like use of accessory muscles of respiration. You can look at the RSBI index, which will be more than 105. The patient is taking less tidal volume, vital capacity. So these are the other physiological criteria which you can use. Arrhythmias, patient may develop arrhythmias during the, after he fails weaning. Or during, sometimes it happens while patient is being given SBT. That time also, if suppose SBT is not successful, patient will develop arrhythmias, altered mental status, and inability to protect the airway. Patient is all pulled up with the secretions, not able to maintain the airway. So now coming to extubation. So extubation refers to, we all know, removal of the endotracheal tube. So this is the final step in liberating the patient from mechanical ventilation. So what are the risk factors for reintubation? So before extubating any patient, we have to really make sure your patient is having a good mental status, patient is having a good cough reflex, patient is able to cough well, and so that there are less chances of pooling of secretions after the extubation. So a weak cough is definitely a risk factor for reintubation. Patient is needing frequent suctionings. Plenty of secretions are there. So that is also a risk factor for possibility of reintubation after you extubate your patient. Patient is having low mental status, GCS score is less than 8. Patient is having a positive fluid balance. Pneumonia is the reason for which you have intubated the patient. You have to be extra careful in ARDS pneumonia patients. Patients who are elderly, they are having chronic respiratory or cardiac diseases, and a reduced or absent cuff leak. So this is also very, very important. I will discuss in little detail about the cuff leak later. So where you are predicting high possibility of reintubation, you can extubate your patient to either non-invasive ventilation or HFNC, or you can use a combination of both. Okay, so that really helps in avoiding reintubations in high-risk patients. Especially NIV is very, very useful when you are planning extubation in COPD patients. In COPD patients especially, you should not be giving very, very prolonged spontaneous breathing trials, because their lung mechanics are such they really don't tolerate it for a long time when they are breathing through the tube. So it is better to give a very, very short SBT and extubate them directly to the non-invasive ventilation. So coming to post-extubation respiratory failure, so of course patient will manifest with drop in saturations, tachypnea, respiratory distress, use of accessory muscles of respiration, stridor. So stridor, I will talk about it, and the most common etiologies are atelectasis from poor secretion failure, clearance, heart failure, aspiration, bronchospasm, and laryngeal edema. Sometimes you may come across in your ICUs accidental extubation. So patient was agitated, was encephalopathic, and he has yanked out the tube. So unplanned extubations can occur in 3 to 12% of the intubated patients. But most of these unplanned extubations, you should not promptly go and start reintubating your patient. So depending upon the clinical situation of the patient, you can really take a call. So just don't straight away go into reintubation. As per the clinical condition of the patient, you can decide whether the patient needs reintubation, or he will be okay without anything, or he will need HFNC or NIV. Now coming to post-extubation stridor, it happens very, very commonly in critically ill patients. So for patients whose initial trial of extubation failed due to stridor, so of course you will have to promptly reintubate such patients, and preferably you will need a smaller size endotracheal tube. So you should keep smaller size endotracheal tube handy when you are reintubating these patients, and they will need a treatment of short course of glucocorticoids. So methylprednisolone 20 milligram is administered every 4 hours for total of 4 doses prior to extubation for the next time. Or alternatively, you can give a single dose 4 hours prior to extubation. And you should always perform a cuff leak test in such patients where you are expecting stridor. So stridor can happen in patients who have been intubated for a very, very prolonged time. So prolonged intubation, elderly patients, a very large endotracheal tube, and where Apache score is high, GCS score is low, the intubation was difficult, it was a traumatic intubation, there is history of asthma and insufficient sedation, aspiration. All these are the possible risk factors for post-extubation stridor. So you have to be extremely careful, you have to do a cuff leak test, and in patients who have sufficient cuff leak test, you can proceed with the extubation. So how do you do it? You have to deflate the cuff, you have to check the volume leak on the ventilator, and a leak greater than 110 ml or more than 24% of the tidal volume, that will suggest that the cuff leak test is positive and you can safely extubate your patient. In patients where cuff leak is absent or it is reduced, you have to delay the extubation. You treat your patients with glucocorticoids, then again perform a cuff leak test, and then you proceed with the extubation. So cuff leak test is very, very important. It is not mandatory in every weaning, but where you are suspecting there can be possibility of laryngeal edema, patient has been intubated for a prolonged time, there was a traumatic intubation, etc. There you have to be extremely careful. Please perform a cuff leak test, and if need be, then you can go ahead with the treatment of glucocorticoids and then safely extubate your patients. These days we have video laryngoscopes also, so where you can actually visualize the cords by giving a short sedation to your patients, where you are seeing the absent or reduced cuff leaks. Now in short about the difficult to wean patients. So the etiologies are patients having a lot of auto-PEEP, your COPD patients with type 2 respiratory failure. You have over-ventilated the patient, especially these patients who are having chronic hypercapnia. You are over-ventilated the patient. pH has shot beyond 7.4. pH is alkalotic. So there is increased renal excretion of soda, the bicarbonate ions. And what happens once you put them on spontaneous, then patient immediately goes into acute respiratory acidosis. So you have to be very, very careful in such patients. Then because of the work of breathing of the endotracheal tube is there for a long time, there are secretions which have lined up the wall of the tube, there is decrease in the caliber of the tube, there is increased resistance that can also cause difficulty in spontaneous breathing. When you put them on spontaneous mode, they have difficulty in initiating spontaneous breaths. Patient is having moderate to large pleural effusions, muscle pump failure. In our critically ill patients, critical illness neuromyopathy is also very, very common. So because of that, there is muscle pump failure. They're not able to initiate adequate breath because of the poor, because of the muscle weakness, respiratory muscle weakness. Then patients with cardiac conditions, sometimes when they are put on spontaneous breathing mode, that time they develop pulmonary edema, they develop ischemia. So weaning induced pulmonary edema, that will happen weaning every time. You have put them on SBT, they go into flash pulmonary edema, or they develop ischemia, they develop arrhythmia, and your weaning is failed. And psychological issues, this is also very, very important. Patient is very agitated, having persistent delirium. These patients are also difficult to wean. Because of the circuit issues, I already told you about the endotracheal tube. Similar issues with the circuit, a lot of dead space, poor compliance of the circuit, that can also hamper your weaning. Dyselectrolytemia, so especially Your potassium is very important. So hypokalemia, hypocalcemia, hypomagnesemia, hypophosphatemia, all these electrolyte disturbances have to be corrected when you have to sort out your difficult to wean patients. You should check TSH levels also in such patients, and nutritional issue. So undernutrition and overnutrition both are derogatory for the weaning. So if you have not fed your patient well, then again patient will be having difficulty in weaning. If you have done the overfeeding, then again that will hamper your weaning. So you have to give optimum nutrition to your patient. So in patients who are difficult to wean, SBTs are longer than the typical 30 minutes, so you can go up to 2 hours. And once daily SBTs to wean patient. The idea is, see, when you are giving SBT, you have given SBT today, SBT has failed. So please don't keep on giving SBTs the same day. Give them rest for the whole day, and then next day again, depending on the situation, you go for the SBT next day. Okay, so don't keep on giving intermittent SBTs throughout the day. If they have failed SBT, give them rest, then try next day. Strategy of extubation with immediate application, this I have already discussed with you. Extubation to an IV works very well with the COPD patients. In cardiac patients also who had undergone like ACS, LVF, cardiogenic shock, there also extubation to an IV works very well. This is also a good strategy. You give 1 hour of rest on ventilatory support. So you give an SBT and then you give 1 hour of rest, and then you go for extubation. That also works well. Tracheostomy can be so in refractory cases, where nothing is working, patient is having very poor muscle effort, or patient is not conscious, GCS is remaining low only, patient is having very poor cough or gag reflex, he is likely to pull up with secretions after the extubation. So in such refractory cases, tracheostomy is the best option. You do tracheostomy of the patient and you wean the patients from the ventilator. So to summarize, first of all, very, very important, the primary cause for which you have ventilated the patient is cleared, is sorted out. Then only you proceed for the weaning. And of course, it is a 3-step process. You have to see the readiness to wean, you have to decide on your weaning strategy, and you have to finally extubate your patient. And this is all I have discussed. And protocolized weaning is preferred. Protocolized weaning is definitely, it will reduce the duration of mechanical ventilation in your ICU settings. Once daily SBT is preferred. Don't keep on giving multiple SBTs the same day. And the SBT should be performed with low level pressure support ventilation rather than through a T-piece. I already discussed with you the advantages. Extubation should not be ordered unless it is determined that patient's medical condition is stable, a weaning trial has been successful, and patient's airway is patent. Patient is able to protect his airway. Then only plan the extubation. And cuff leak test should be done when you are suspecting, when you are having the doubt that patient is more likely to have post-extubation stridor. And once the potential causes have been identified and treated, you may resume the SBT. So like this I have already discussed. Yeah, this is very, very important. Early mobilization and physical therapy. So most of the times we are dealing with critical illness neuromyopathy. So early mobilization, physical therapy is very, very important so that you achieve liberation of mechanical ventilation as early as possible. And in COPD, extubation to an IV is preferred. In cases of high risk of extubation failure, you can extubate them to NIV or HFNC. And in refractory cases, tracheostomy is preferred. Thank you.
Thank you, ma'am. I would request Dr. Bharat Jagyasi sir to felicitate Dr. Archana ma'am. I would request Dr. Nikhil Varghese sir to felicitate our chairpersons, Dr. Bharat Jagyasi sir and Dr. Prashant Zedge sir. So now we will have a lunch break of 35 minutes, and after that we will resume for the hands-on training.
Hello, hello, my test. Hello, 1, 2. Hello, 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 my test. Hello, hello, my test. Hello, hello, my test. Okay.
Dr. Yogesh, I would like to request to please felicitate Dr. Sagar Sinha sir.
सर्टिफिकेट, अरे मैं दूंगा ना, अरे खुशी खुशी वेट 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 वेट, अभी मत दो किसी को, लेट मी गिव इट, वेट वेट फॉर 5 minutes ओनली. चलो, can I ask everyone? Acha, so this concludes our 2-day airway and mechanical ventilation. I'm sure we would have added some knowledge to your practice, and I hope you will practice it at your ICUs, and maybe you will be a better intensivist now. even after this, I say this to everyone, even after this, if you have any issues, whenever you are working in ICUs, you find it difficult to ventilate a patient, or you find any difficulties, you can contact us after that also. Okay, so at the end I would like to thank first of all you to take out time thinking that you need to come, learn and understand. After that, I would like to thank all the esteemed faculty who have taken time, come from Pune even. So a lot of people have taken out their time. Third, I would like to thank my department, critical care. They have done a lot of effort, Dr. Nikhil. And finally, last but not the least, the very important work done by the marketing team. They have been working relentlessly. So I would request all of you to come to stage one by one and take your certificates. Then we will have a group photo and then you can leave within 5 minutes, right? So please start to come.